Who will start? Okay. Hi guys, Dr. Sara here. I hope you can see me. Am I audible, visible to all of you? Am I audible, visible to all of you? I'm sorry for the delay. I'm sorry for the delay. Yeah, I hope you're all here. Can you just give me a yes if you can hear me and we can begin? Hello? Yeah. Okay, guys. So look at the first question. If you can see the first question. क्या हो गया? कुछ हुआ? So if you can see the first question, there's if you can see the first question, look guys, there's a man with chest pain and shortness of breath. Histological exam shows you this myocardial tissue. And as you can see here, there is this infarct, right? There is an infarct. And this shows you that this is in a solid organ. Solid organ, right guys? So in the solid organ, there's an infarct. What is the most common cause of this? Firstly, if you can see, infarct means this is coagulative necrosis. Coagulative necrosis, right? Stop. I am not live yet. Arise. I don't know, Rahat bola. Guys, can you hear me? Is it lagging or can you hear me? Can you see? Hello, can you hear me? Can you hear me? Hi guys, am I audible? Am I audible? I'm so sorry for the delay. I hope I am audible and visible. Let's start without any further delays. So in the first question, you can see there's an infarct and this is solid, right? And solid organs, the solid organ get affected by coagulative necrosis. If you can remember, it is coagulative necrosis that affects the solid organs, all solid organ except for your brain, except for brain. Okay, brain undergoes liquefactive necrosis. You all know that, right? It has a lot of hydrolytic enzymes, so it undergoes liquefactive necrosis. Also remember one more thing. As you can see the infarct, if I can integrate it with the other side of patho, what can you put this in around 1 to 4 hours? How do you see whether a person on autopsy, how do you see whether a person is, having this infarct? So what you do is you put the specimen in tetrasodium dye, okay, tetra-blue sodium dye. All right. I hope you're able to recall all of this. Very good. Very good. Triphenyl, tetrasodium stain, okay, dye. All right, you put it inside that, and then you come to know that the unstained area is the one that has undergone necrosis. All right, remember this stains the area where the LDH is lost. So you might have understood that there is an LDH flip, right? LDH flip. What happens in an LDH flip? Usually in the serum, we have LDH2 more than LDH1. But here there is LDH1 more than LDH2. I hope this is all clear to you. And the most common cause of coagulative necrosis is ischemia. Okay, there must be some emboli or some thrombus due to which there is ischemia, right? There is ischemia. Now, brick red color will color the stained area. Unstained area will be brick red will be where you have the presence of LDH1. LDH1, where it is not there, is your, just give me one sec. Yeah. LDH, where LDH is lost, that is unstained. Okay, that is unstained. And remember your LDH flip. Okay. All right. Also remember the other examples of coagulative necrosis. You have liquefactive necrosis, where brain is affected as well as your pancreas. Okay, remember pancreas also undergoes liquefactive necrosis. What happens here? The tissue architecture is lost, right? Tissue architecture is lost. It can also occur in abscesses. What about coagulative necrosis? Like I told you, it affects most solid organs except for your brain. Okay, and you see a wedge-shaped infarct here. I'm going to show you the infarct. Caseous necrosis is actually a combination of both liquefactive and coagulative necrosis, more liquefactive, and it is seen in tuberculosis, systemic fungal infections like histoplasmosis or coccidioidomycosis. Okay, what about fat necrosis? As you remember, it is seen in your pre-pancreatic fat due to enzymes like lipase or amylase, and breast due to trauma. Now, what is this? What is this? You can see the chalky white deposit. This is seen in fat necrosis. Okay, this is seen in fat necrosis, and you have the white chalky deposits. All right, white chalky deposits. Okay, in the mesentery. And this is due to saponification because of free fatty acids binding to calcium. Okay, this is nothing but saponification. I hope you're able to remember this. Yes, very good, guys, very good. What about this one? You can see this is a cut section of your brain, and you can see this infarct which has lost its tissue architecture, right? So this is actually liquefactive necrosis. Okay, liquefactive necrosis. While this cheesy appearance, you can appreciate the cheesy appearance on the lungs. So most likely a case of TB where you have cheesy appearance. So cheesy appearance is happening because of increase in lipid content from the cell wall of your TB bacilli, right? Yes. So this is seen in Which necrosis? Yes, this is your caseous necrosis. Very good, guys. Very good. Yes, yes. Very good, very good. Here you see a wedge-shaped infarct, right? This is seen in coagulative necrosis. Okay, wedge-shaped infarct. Remember, your tissue architecture is maintained. What about this? When you take this, the histopath of this, you'll see a lot of ghost cells. Okay, so nucleus is lost, and you see these ghost cells. And this is known very famously as the tombstone appearance. Tombstone appearance. Okay, tombstone appearance, where the tissue architecture is lost. Tissue architecture is maintained, but the nucleus is lost. Okay, what is lost here? Nucleus is lost. Nucleus is lost. Yes, very good, guys. Tombstone appearance, the row of tombstone appearance, if you remember, row of tombstone, that is seen in, can anybody tell me where is this seen in? This is seen in pemphigus vulgaris. Okay, due to your desmoglein 1 and 3 defect. Okay, desmoglein 1 and 3 defect. Very good, guys, very good. What about this pinkish material in the tunica media? All right, this is actually a case of fibrinoid necrosis. Fibrinoid necrosis, where you see this pinkish fibrinous deposit coming out of the blood vessel in tunica media. And this is seen in cases where there is immune complex deposition, like type 3 hypersensitivity. An example, a very common example is polyarthritis nodosa. Remember, this patient will present to you, like 30% of the cases will present with HBsEg positivity, meaning they'll be positive for hepatitis infections. Okay, hepatitis infections. Now, what about this? These are your clinical necrosis. What are these? This must be the wet gangrene because it is shiny. Okay, so this must be wet gangrene. Remember, wet gangrene is nothing but a form of liquefactive necrosis. Why? Because it's shiny, it does not have a proper line of demarcation. Okay, plus you will have the presence of edema plus infections. Okay, edema plus infections. What about this one? If you can see, this is a form of dry gangrene, which happens due to mostly ischemia, right? Or a thrombus formation. That's why the line of demarcation is very clear. Okay, line of demarcation is very clear. All right, very good, very good. Now look at this. These are the differences between your reversible as well as irreversible injury. The one thing that I would point to in your irreversible injury are the nuclear changes. Remember, you can see pycnosis, karyolysis, and karyorhexis. It's actually pycnosis, karyorhexis, and finally karyolysis. All right, these are the nuclear changes in irreversible injury. Let's go to the next question. A 50-year-old woman undergoes a pap smear and you see dysplastic cells in the cervix. Dysplasia is characterized by. Can anybody tell me what dysplasia is characterized by? So if you remember, dysplasia is actually a pre-malignant change. Okay, it is a pre-malignant change. And this comes after metaplasia, right? This happens after metaplasia. If the injury keeps on increasing, then you have dysplastic cells where there is a loss of cell uniformity and architectural orientation. What about your increase in cell size? That is seen in hypertrophy. Decrease in cell number as well as cell size is seen in atrophy. Okay, is seen in atrophy, while conversion of one cell type to another is metaplasia. I hope you remember your cellular adaptations. This happens. These are all reversible. Okay, these are all reversible. All of them are reversible. Okay, all of them are reversible. And what happens after dysplasia? Yes, definitely, anaplasia takes place, where anaplasia is the hallmark of malignancy. Okay, anaplasia is the hallmark of malignancy, where there is lack of differentiation. Lack of differentiation. Okay, very good, very good. Yes, metaplasia is 100% reversible. Now let's just go through the images of pap smear. If you remember what instrument is this? Can anybody tell me what instrument is this? Can anybody remind me what instrument this is? So this is your speculum. Which one? 𝗲𝗄 speculum. Okay, 𝗲𝗄 speculum. Through this, you actually increase it. With this, you open the vagina and you see the cervix, and then you use these two instruments. What are these? This is your Eyer spatula. Okay, and this is your, which brush is this? Which brush is this? Yes, very good. This is your cyto brush. So cyto brush, actually we take the sample from the endocervix. Very, very important to remember. We take the sample from the endocervix, while your Eyer spatula, we take the sample from transformational zone. Okay. Then you also have one more brush, which is the 𝗬𝗏𝗃 brush. Okay, 𝗬𝗏𝗃 brush. So this is actually used for liquid cytology. All right, this is used for liquid-based cytology. Liquid-based cytology. So these are the instruments of your pap smear. Remember, this is the 𝗲𝗄 speculum. This is your Eyer spatula. Where do you take the sample from? From the transformational zone, and cyto brush, endocervix. While this is your 𝗬𝗏𝗃 brush, which is used for liquid-based cytology. Okay. Again, this part stains the transformational zone, while this stains the endocervix. Very good. When you take this sample, right? Once you take the sample, once you see it under histopath, what do you see? You see this cells, okay, where you have the presence of perinuclear halo around it. Okay, there's a perinuclear halo. These cells are known as koilocytes. Very, very important. They're seen in HPV. And HPV, remember, if I ask you the diagnosis of this question, you can tell me it is plastic cells are seen. So most likely this is carcinoma, cervical carcinoma in situ, right? And the most common cause of that is HPV. Okay? So malignant transformation, what are the proteins responsible for that? If you remember, E6, which blocks out your P53, and E7, which blocks out your RB gene. Remember, these genes are tumor suppressor genes, right? So very, very important. Now your high risk subtypes, if you remember, these are your 16 and 18, which are known to cause. Remember, 16 is most common, while 18 is most specific. Okay, 18 is most specific. Remember them. 16 is most common, while 18 is more specific. While if you remember, your HPV is also known to cause genital warts, right? It is also known to cause genital warts. So can anybody tell me about genital warts? What are the subtypes that cause genital warts? So if you remember, it is HPV 6 and 11. 6 and 11. And what is this actually? What image is this? Can anybody tell me? This is your condyloma. Condyloma acuminata. Acuminata. All right. Remember, LATA. LATA is seen in secondary syphilis. Secondary syphilis. Condyloma lata is seen in secondary syphilis. All right. I hope this is clear to all of you. Yes, very good. Very good. Sindhuja, Megha, Ananda, Mohammed. Very good, guys. So these are the different, definitions and mechanisms of all your cellular adaptations. While if you can see, I'll share a few more images. What is this? This is nothing but hypertrophy of your interventricular septum, and this is seen in HOCM, okay, hypertrophic obstructive cardiomyopathy. You see a very characteristic banana-shaped appearance of the left ventricle, right? So if you remember your banana appearances, where all do you see your banana appearances? Look at this. This is nothing but a peripheral blood smear. And you see here, what do you see here, guys? What do you see here? You see this banana-shaped gametocyte, okay? So banana-shaped gametocyte in Plasmodium falciparum, right? What about this? This is your banana-shaped cerebellum, right? And this is seen in the ultrasound of banana-shaped gametocyte. There are two signs here actually, the lemon sign. This is the lemon sign and the banana sign. Remember, this is seen in spina bifida, the ultrasound of spina bifida. Okay, spina bifida. What about this one? You can see very clearly, this is also known as the crescentric sign or the banana appearance. So this is seen in SDH, subdural hematoma, which is actually because of, yes, this is due to the rupture of bridging veins. Okay, bridging veins are ruptured. Okay, and the investigation of choice for all head trauma is NCCT. Okay, myositis ossificans, this is an example of metaplasia. Okay, what is happening here? The muscle is turning to bone. Okay, muscle to bone. Muscle to bone. Right? What about this one? Very good, very good. What about this one? This is actually, you can see there is atrophy of your thenar eminence. All right, why is this happening? Because of denervation. Remember, this is a kind of atrophy. So again, there is a decrease in size as well as number. Thenar eminence, the muscles in the thenar are affected. Why? Because this is related to which nerve? Median nerve. Okay, carpal tunnel syndrome. And here this is starvation or malnutrition atrophy. Malnutrition atrophy. And if you remember, here you don't see any kind of edema. So the only two protein energy malnutrition that we have is kwashiorkor and marasmus. So this must be marasmus. Remember, there was a PYQ about your kwashiorkor as a fat sugar baby. Okay, fat sugar baby. Remember, edema presence in kwashiorkor. Okay. Okay, very good. Let's look at the next question. A patient undergoing cancer treatment develops severe side effects due to excessive apoptosis in the gastrointestinal tract. Which protein is overexpressed? Could potentially protect from apoptosis. So look at the options. P53 is pro-apoptotic. Okay, it actually induces apoptosis. What about your LC3? It is actually a, what do you say, a marker for autophagy. Remember this, LC3 is a marker for autophagy. What about caspase-8? Again, this is caspase-8 and 10 are involved in the extrinsic pathway of apoptosis. So what is the answer here? What is anti-apoptotic? It is your BCL2. All right, anti-apoptotic is BCL2. So remember your pro-apoptotic markers. What are these? P53, BAC and BACs. BCL excess. What about your anti-apoptotic? Everywhere, wherever you see an L, okay? MCL1, BCL2, MCLXL. So remember, they are long-living. Those are your anti-apoptotic, and sensors include the 𝗬𝗵𝗵𝗵𝗵𝗵, noxaPuma. Okay, these are the differences between apoptosis and necrosis. While just go through this when I share the PDF. Remember, inflammation is a part of necrosis. Why? Because the cytoplasm is leaked. But here you have no inflammation. Okay, you don't have inflammation in apoptosis. How do you diagnose apoptosis? The marker is annexin 5. Remember, annexin A1. Annexin A1 is seen in hairy cell leukemia. Okay? Other markers like a molecular marker is CD59, which is a marker of extrinsic pathway, and microscopic examination, you can see that there is condensation of the nucleus. Look at the cell, compare it with the cells next to it. So you can see the cell has condensed, and you have the condensation of the nucleus as well. So nuclear chromatin condensation is a very, very, very important marker microscopic examination that you see. And on gel electrophoresis, what do you see? This pattern on B is actually the step ladder pattern, which is seen in apoptosis, while necrosis shows you a smear pattern. Okay, necrosis shows you a smear pattern. All right. Can I go to the next question? Can I go to the next question? Yes, let's go to the next question. Look at this. A lung biopsy is obtained from a patient with chronic productive cough, recurrent respiratory infection, hemoptysis, and shortness of breath. Okay, shortness of breath. Now, what do you see here? You see bronchial wall is thickened and dilated airways. So most likely, can anybody tell me what must be the diagnosis where there is dilatation of the bronchi? Okay, most likely diagnosis is bronchiectasis. Okay, bronchiectasis. And you must know that this is actually one of the features of bronchiectasis. One of the reasons why, genetic reasons why this happens is Khader-Jenner syndrome, right? Do you remember Khader-Jenner syndrome? And if you remember, there is a triad of Khader-Jenner syndrome. What is the triad of Khader-Jenner syndrome? Can anybody remind me that? There is bronchiectasis plus sinusitis and situs inversus. Infertility is also seen, but it is not part of the triad. So this patient who had bronchiectasis has the presence of amyloid. And how do you stain amyloid? Remember, the stain is Congo red. Alcian blue is used for staining mucin. Okay, and a very good example of staining Alcian blue is Barrett's esophagus. If you remember, Barrett's esophagus is nothing but a kind of intestinal columnar metaplasia where you have goblet cells, and these goblet cells contain mucin, which can be stained by Alcian blue. Silver stain or Komori's methenamine silver stain can stain basement membrane, or it can stain fungi. Okay, this can stain fungi. While your Mason's trichome, what does Mason's trichome stain? It stains collagen. Okay, it stains collagen. I hope you're able to remember all this. Now, when we talk about amyloid, it gives you a very characteristic. This is actually a glomerulus, and you can see the salmon pink appearance on Congo red. The same thing on polarizing light shows you an apple green birefringis. Okay. All right, apple green birefringis on what? On polarizing light. Okay, polarizing light. Remember this. This is very, very important. Then these are the different types of amyloid in different positions. Like these all have been asked in the exam. So very, very important. As you can see, bronchiectasis is associated with AA type of amyloid. All right, your RCC, Hodgkin's lymphoma, a genetic factor which is familial Mediterranean fever. All of them are associated with amyloid associated amyloid. A-beta-2 microglobulin is associated with hemodialysis. AL is the primary amyloidosis, okay, which is associated with multiple myeloma. Very, very important. Please go through this. All of them are previous year questions. ACAL has been asked in INESET question this time. Okay, all right. These are the different stains for your examination that are important. Just a quick overview. We're very close to the examination. So a quick overview, like melanin. If you remember, M4M, Mason Fontana. And the IHC markers include HMB45, which is the most specific. The other markers are all here. The other stains are all here. Please go through them. They're very important for the exam. Okay, all right. These are, if you can see, these are nothing but your oil red O. Oil red O, staining lipids. You can see lipids have all become red. And this is done on frozen section. We use cryoprecipitate here. Okay. What about this one? This is actually your Sudan. You can see the black color, right? So Sudan black B. Yes, very good, very good. What about this one? You can see that this is the cardiac myofibrils, and next to the nucleus, perinuclear in position, this is actually golden brown pigment. This is your lipofuscin. Very important for the exam. Lipofuscin is golden brown. It is also known as wear and tear pigment. It this is happening because of lipid peroxidation, okay? Telltale sign of free radical injury. What about this? Is actually either your basophil or your mast cell. Okay, mast cell. And what is the stain that we use here? We use the stain toluidine blue. Very good. Toluidine blue. Very good, very good. What about this one? This is very, very famous. So this is nothing but iron or hemosiderin. It can be iron or hemosiderin. And you know, this is seen. How do we stain it? With the help of pearls. Yeah, Prussian blue. Yes. Thank you, thank you. What about this one? This is your Mallory-Hyland bodies. Yeah, Mallory-Denk bodies, where you have cytokeratin. Okay, you have the presence of cytokeratin. Which one? 8, cytokeratin 8 and 18. This is seen in alcoholic liver disease. There are so many other diseases, right? Remember this. This is an important question in the exam. Okay. And this is nothing but your past stain, the magenta color. Okay. So there was a reel going on, right? The wow. Yeah, past stain, which is actually staining magenta. Remember, past is positive for glycogen. Glycogen is past positive as well as diastase sensitive. What about this? You can see this is the epidermis, and in the basal part, okay, stratum basale, what can you see? There is staining, right? And this is nothing but melanin. All right. And what is the stain here? Mason-Fontana. What about this? As you can see, this is Mason trichome staining the collagen blue. Stains collagen blue. Okay. Collagen is stained blue. Okay. What about this one? This is actually calcium. So this must be the stain which is known as 𝗏𝗂𝗃𝗃. So there are two stains for calcium, alizarin red and 𝗏𝗂𝗃𝗃. Okay. Alizarin red also stains little amount of calcium. Okay. These are the different types of calcification, very important for your exam. Just a quick overview, okay? Metastatic and dystrophic. Dead and degenerating tissues or dead and damaged tissues have dystrophic, while living tissues have metastatic. So just quickly go through this the last minute, okay? Let's look at the next question. A 40-year-old woman experiences pain and swelling after a sprain. Which mediator is responsible for pain? So TGF-beta, look at TGF-beta. Beta, bro is hard. So I always remember it like that. It causes fibrosis. Okay, it is involved in wound healing. It causes fibrosis. Okay, so TGF-beta is activated when macrophage, the alternative macrophage is activated, right? So it causes fibrosis. Remember, this is important. It causes wound healing. It is anti-inflammatory. What are your anti-inflammatory markers? Interleukin 10, TGF-beta, and then you also have anybody. If you remember from your arachidonic acid pathway, you get lipoxins. These are all anti-inflammatory. What about histamine? Histamine, again, it has three functions. It causes increase in plasma. It causes vasodilation, increased vascular permeability, and bronchoconstriction. Now, prostaglandin E2 is the one which causes pain and fever. Okay, pain and fever. Remember your bradykinin. Bradykinin also causes pain. It also causes pain. Okay? Interferon gamma causes macrophage activation. Very, very important. It causes macrophage activation. Okay. Again, causing granuloma. It can lead to granuloma formation. So these are the differences between histamine and serotonin. Remember, histamine, this has been a PYQ where they've asked you the maximum concentration. Where do you see? In mast cells, okay? And that's why histamine is also one of the mediators in your type 1 hypersensitivity, okay? What are the functions? Vasodilation, bronchoconstriction, increase vascular permeability, okay? Your serotonin, it is derived from tryptophan. So quickly, just tell me, tryptophan, what does it give you? It is a precursor of what? It is a precursor of melatonin, of serotonin, and niacin, okay? Remember, niacin causes pellagra. You remember your 4Ds? Casal's necklace? Very, very, very important. And an increase in serotonin levels. Increase in serotonin levels will cause carcinoid tumor. Right? Do you remember this? Yes, very good, very good. Let's look at the next question. A 25-year-old woman has a red, hot, swollen left knee. She has no history of trauma or joint disease. Aspirin relieves her symptoms. It inhibits which of the following? So if you remember your arachidonic acid pathway, your aspirin actually is an NSAID. So it will inhibit both COX-1. It will inhibit both COX-1 and COX-2. Okay, COX-1 and COX-2. Yes, very good, very good. It inhibits both COX-1 and COX-2. So this is actually going to inhibit the cyclooxygenase. Can anybody tell me selective COX-2 inhibitors? Selective COX-2 inhibitors. So these are nothing but your 𝗙𝗵𝗂𝗁𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃𝗃 you have 5-LOX inhibitor, right? That is your xylutine. What about phospholipase A2? This is inhibited by steroids. This is inhibited by steroids. And then xanthine oxidase is inhibited by allopurinol. Very, very important. This is given in chronic gout. Drug of choice for chronic gout. While your NSAIDs are the drug of choice for acute gout. I hope you're able to remember this. Yes, yes. Very good. Very good. Sahana, very good. Punit, Ravi, very good. Okay, so this is your pathway, your arachidonic acid pathway. You know it differentiates into COX and LOX. So 5 from your LOX, just remember LT-C4D4E4, which are actually so slow reactive substances for anaphylaxis. And how do you inhibit this? You give leukotriene antagonist, right? Receptor antagonist. All right, leukotriene receptor antagonist. So you must have heard of montelukast and zafirlukast. So these are your leukotriene receptor antagonists, right? What about all these? Please go through them. They're very, very important for the exam. Let's go to the next question. A 2-year-old child with recurrent bacterial infections, including pneumonia and otitis media. Lab shows a very low level of all immunoglobulins. So there must be an absence of immunoglobulins. Flow cytometry reveals a lack of CD19. If you remember, CD19 is a pan B cell marker. Okay? Pan B cell marker. Okay? So they are showing you a decrease in all B cells, all type of B cells. So what must this be? Is it 𝗬𝗵𝗃𝗃 syndrome, chronic granulomatous disease, Bruton's, या DGeorge? So if you remember, 𝗬𝗃𝗃 is a list gene defect. And here you have defective phagolysosomal formation. And I think you are able to remember that there is CNS delay, development delay here. There is bleeding manifestations, recurrent infections. There's also oculocutaneous albinism that you see in 𝗬𝗃𝗃. What about chronic granulomatous disease? This actually, CGD, is a defect in FOX gene. Okay, this is a defect in FOX gene. And if FOX gene is defected, NADPH oxidase deficiency is seen. Okay, NADPH oxidase deficiency is seen. And now if you don't have NADPH oxidase, oxygen dependent killing is affected. I hope you're able to remember that. So one thing to remember in NADPH oxidase, the organisms that they talk about will be catalase positive. Okay, catalase positive organisms. The recurrent infection from catalase positive organism, because they neutralize H2O2, right? Because of that, you have catalase positive organisms, plus DHR is the investigation of choice, dihydrorhodamine test done through flow cytometry, and NBT, nitroblue-tetrazolium test, is a screening test that we use. Okay, remember this NBT, if the color is blue, remember it is normal. Okay, so normal is blue. I remember normal is blue. If it becomes yellow, it is abnormal. Normal is blue. Remember that. So here, there is an absence of all immunoglobulins. So we are talking about Bruton's A-gamma globinomia. What about DiGeorge syndrome? DiGeorge syndrome, you have to remember everything related to 2. Okay, everything related to 2. Very good. I hope you're able to, revise everything that we have studied, that we have done. DiGeorge syndrome is a defect in 22q11.2. And because of that, I always tell you in the classes, 2 organs are affected, 2 pouches are affected. What are the 2 pouches that are affected? 3rd and 4th pharyngeal pouch. Okay, 3rd and 4th pharyngeal pouch. As these are affected, now 2 glands will be affected, like your thymus and parathyroid. Right? And because of that, the 2 consequences that you see is recurrent infections, because thymus, what matures in your thymus? Your T cells mature, right? So you have recurrent infections as well as hypocalcemia. Okay? Recurrent infections as well as hypocalcemia. So I hope you're able to recall this. DiGeorge syndrome is very, very important. It has come in exam many times. Okay, it has come in the exam many times. If you can remember 2 more things that happens to the organs, what other 2 things happen? There is a cardiac congenital defect in the heart. It is associated with tetralogy of Fallot, which is your previous year question. And it presents with cleft palate. Okay, cleft palate, abnormal feces. So that is cleft palate. So remember, this is all about your DiGeorge syndrome. Bruton is everything with B. What is affected? Your BTK gene is affected. Okay, BTK gene. I'm just going to write it here. BTK is affected. BTK gene. That affects the B cells. And as B cells are not there, immunoglobulins are lost. Okay, this is all you need to remember. Also remember that it is most commonly seen in males because it is a X-linked recessive disease. Okay, X-linked recessive disease. I hope you're able to recall all this. Very, very, very important. 4 options that have come in your exams, will come in your exams. Again, CGD was asked in your previous Jan 2024 exam. Okay, these are the vascular and cellular events in your acute inflammation that you need to go through. If you don't know this, you will also not know the primary immunodeficient disorders related to this, right? And these are some short notes that you can go through. Remember, LAD1 is a defect in integrin. Okay, while LAD2 is a defect in Salil Lewis X. Okay, what happens in LAD1? You have absence of pus as well as delayed separation of cord, because necrosis of the cord is not happening, right? So these are some things that you need to go through before the exam. Just one fast reading. Okay, let's go to the next question. Look at this. A 25-year-old male has been experiencing fever, generalized malaise, cough for the past 15 days. Upon examination, there is a cervical lymph node. A biopsy was conducted revealing specific characteristics under the microscope as shown below. What is the most likely diagnosis? Guys, can anybody tell me? So what you see here, you see that there is a loss of cells, right? Loss of cells and only pinkishness. This must be necrosis. Okay, this must be necrosis. And at the end, at the edges, you can see these giant cells. Okay, what do you see? You see the presence of giant cells. All right, the presence of giant cells. What do you see? The presence of giant cells. Okay. So this must be your granuloma. Which kind of granuloma? Caseating granuloma. Because which necrosis is this? It is caseating necrosis. So this is seen in which of the following? Is it Hodgkin's lymphoma, sarcoidosis, or cat scratch, or tubercular granuloma? Remember, this is tubercular granuloma. Cat scratch will show you a kind of stellate granuloma. Okay, it is a special granuloma. Stellate granuloma, right? And this is seen in two conditions. One is your LGV, lymphogranulum verinum, LGV, because of chlamydia trachomatis. Okay. What about the next thing? It is seen in cat scratch disease caused due to Bartonella-Hensleigh. Okay, Bartonella-Hensleigh. Remember, this is your previous year question. Okay. Sarcoidosis shows you a non-caseating granuloma most commonly. So does Hodgkin's lymphoma. All right. Okay, very good, very good. So these are the different types of granuloma that you have. TB, as well as everything you learn in caseating granuloma are the examples here, while Hodgkin's lymphoma, sarcoidosis, TB, and leprosy, all of them will show you non-caseating granuloma. Hodgkin's lymphoma will also present with painless lymphadenopathy, right? And immune granuloma are seen in two conditions, two actually. Vasculitis. If you remember your vaginous granulomatosis, it is a vasculitis, and giant cell arthritis, temporal arthritis is another vasculitis. Giant cell arthritis, what do you remember? How is the age here? More than 50-year-old female will be there, and she'll come with headache. Okay, the most common symptom is headache. The most specific symptom is jaw claudication. Okay, she will have pain while chewing. And the most dangerous symptom is when there is involvement of ophthalmic, yes, branch, ophthalmic artery that can lead to blindness or loss of vision. Okay, so very, very important, giant cell arthritis. The other the other arthritis that affects your large vessels is Takayasu. I hope you remember that. I hope you're able to recall that. This is the stellate granuloma I was talking about. What about this? This is actually a kind of parallel lines that you see with the presence of schizons in the middle. This is cerebral. This is a kind of granuloma known as Dirk's granuloma, seen in cerebral malaria, which is caused by Plasmodium falciparum. While this ring here, this ring, what is this granuloma? This is your donut granuloma seen in Q fever. Okay, Q fever. So these are some different kinds of granuloma that you need to remember. Plus, these are some giant cells that are very important for the exam. So this giant cell is actually Langerhans giant cell seen in TB. Okay, this is seen in TB. While if you remember your Langerhans cell is an antigen presenting cell. Okay, dendritic cell, antigen presenting cell. Please be able to differentiate between these two. And it shows you Birbeck granules on electron microscopy. Do you remember that? Very, very important tennis racket appearance. Very, very important finding. Yes, it is seen in the skin. These are antigen presenting cells of the skin. Langerhans giant cells are nothing but these horseshoe appearance. Okay, these giant cell with the horseshoe appearance. Very famous horseshoe appearance. What about this? Now this is your two-tone giant cell. If you can see, there are nuclei arranged in a in a circle with fat. The whiteness is nothing but lipid deposition. This is a two-tone giant cell seen in xanthoma. Okay, so the cytoplasm is vacuolated with lipids. Okay, so it is also known as the wreath-like arrangement. Okay, wreath-like arrangement of nuclei. Okay, wreath-like arrangement. Just be able to remember this. What about this very, very famous giant cell? Very famous giant cell has come in the exam so many times. So this is actually your 𝗏𝗏-Finkeldy giant cell. Remember, it has both intracytoplasmic. You can see bodies here, intracytoplasmic, as well as intranuclear. Okay, intranuclear inclusions. So both the inclusions are seen, intracytoplasmic as well as intranuclear inclusions. This is seen. Where is it seen? It is seen in measles. And if you remember the incubation period of measles, it is IP is 10-14, right? 10-14. Also remember the 3 C's of measles: complex spots, 𝗬𝗄𝐶, coryza, and conjunctivitis. Very good, very good. All right. I hope you're able to recall all this. And when do you give your MMR? MMR is given at the 9th month. Okay. Yes, very good, guys, very good. What about this, where you have the haphazard arrangement of nuclei? Nuclei are everywhere. Remember, this is your foreign body giant cell. Okay, it can happen because of suture or talcum from the gloves. All right. Look at the next giant cell. Now, this is your osteoclastic giant cell. It is a physiological giant cell. Osteoclast is nothing but your bone resorbing cell, right? What about this? This is actually your owl eye appearance. Owl eye appearance. So there are 2 giant cells with the owl eye appearance, right? One, so you have 2 cells. If you have pink nuclei, okay? Pink nuclei. So if you have the appearance of pink nuclei, remember this is a Reed-Sternberg cell. This is a Reed-Sternberg cell seen in Hodgkin's lymphoma. Okay? But the same thing, if this nuclei is bluish, okay? If this nuclei is blue, if this nuclei is blue in color, then that is CMV. Plus also you have intracytoplasmic inclusions. So this is seen in CMV, okay? So both intracytoplasmic as well as intranuclear inclusions. Both of them are seen in this condition, all right? Both of them are seen. Also remember, your CMV is a very common infection in post-transplant patients. Okay? This is a previous year question that you need to remember. Very important. Okay? This is your classical Reed-Sternberg cell, right? Plus all these giant cells are made up of nothing but macrophages. So this is one more PYQ that you need to remember. What are the different types of macrophages in different organs? In brain, they are known as microglial cells. In the lungs, they are known as alveolar macrophages. Liver was the previous year question that you had, right? Littoral in spleen, yes. Littoral in spleen. Mesangial cells are nothing but cells of the kidney. And Hofbauer in placenta. And osteoclast in bones. Okay, so can anybody tell me what is the tumor of osteoclast? What is osteoclastoma? Osteoclastoma, very, very famous question, right? Osteoclastoma. It is a tumor of osteoclasts, right? It is nothing but your very famous. Which tumor am I talking about? It is your giant cell tumor. Giant cell tumor, because osteoclasts are nothing but giant cell, right? So this is why it is known as your giant cell tumor. And this is actually an epiphyseal tumor, right? Epiphyseal tumor. And it has a very famous appearance, which is the soap bubble appearance. Okay, soap bubble appearance. Yes, yes, very good, very good. Chalo, let's look at the next question. A 35-year-old thickened raised scar on the forearm, but the scar remains confined to the borders of the original bone. Which of the following best describes this scar? Can anybody tell me? Can anybody tell me which of the following best describes the scar? So remember, you're very good, very good. So Manoj, Bhavna, Stuti, Sindhuja, very good. So keloid is out beyond the wound margins. Remember, keloid is beyond the wound margins. Your keloid is beyond wound margins. What about hypertrophic scar? Yes, this is the scar that is a raised scar, which is within the wound margins, and the collagen that is affected here is type 3 collagen, right? Type 3 collagen. What about contracture? Contracture usually happens in patients who undergo burns, right? So because of burns, there is limitation, physical limitation. So this is seen in cases of burns, while proud flesh is nothing but an excess of granulation tissue. Okay, excess of granulation tissue. So it is also known as exuberant granulation tissue, okay? And remember, granulation tissue is the hallmark of wound healing. Okay? Granulation tissue is the hallmark of wound healing. So this is a image where you see a lot of redness. What must this be? This is your proud flesh. Okay, it becomes very reddish because granulation tissue is made up of new blood vessels, right? It is made up of new blood vessels. So this is your proud flesh. This is a deficient in wound healing that can lead to ulcers. You can see these ulcers in diabetic foot or pressure ulcers, right? What about this one? This is on the sternum. You see the presence of keloid. Sternum or earlobe. And this is your hypertrophic scar, where it is within the wound margins. Okay, so this is your hypertrophic scar, right? All right, very good, very good. Now these are the differences between keloid and your hypertrophic scar. Very, very important. Remember, triamcinolone has been asked in your exam. How do you treat a keloid? You give intralesional steroids. Okay, intralesional steroids are given. And which one? Triamcinolone. Okay, very good. This was a question that was asked in 2020, FMGE 2020. Very important. Okay, plus also the factors that promote wound healing. Very important, vitamin C and zinc. Okay, because zinc helps in MPPs, right? So it is a cofactor. Or even copper. Copper is also a cofactor in MPPs. So copper ho gaya, zinc ho gaya, vitamin C. It helps in wound healing. Okay, and vitamin C is so important because there are 4 functions of vitamin C that you need to remember. Only 4 functions. I'll tell you about it. Vitamin C, it causes wound healing. It helps in wound healing. That is already written, so I won't write it. It also helps in collagen synthesis. Okay, it helps in collagen synthesis. It is also an antioxidant. Okay, collagen synthesis, antioxidant, plus it increases iron absorption. So all these are your previous year questions. Iron absorption has been asked many times in the exam. Even your Jan 2024 question, they were asking about what inhibits. You know, there was a case given with the options as coffee, tea, tea, catenins and all that. So iron absorption, what increases iron absorption and what decreases iron absorption is very important for the exam. Vitamin C deficiency can lead to scurvy, the bleeding of gums, again because collagen synthesis is affected. Zinc deficiency can lead to a condition, a dermatitis-like condition. What is that known as? Acrodermatitis enteropathica. Okay, acrodermatitis enteropathica. Okay, I hope you're able to remember that. ठीक है? Most common cause of delayed wound healing is infections. This is also previous year question. Now look at this question. A 65-year-old man was hospitalized 2 weeks ago for a cerebral infarction. He is now ambulating for the first time. Within minutes of returning to his hospital, he has a sudden onset of dyspnea and cannot be resuscitated. On the hilum, you see this figure. What is the factor responsible? So what do you see here? You see a emboli, right? And this emboli is red in color. So most likely a venous emboli. Okay, most likely a venous emboli, right? Venous emboli. So what can be the cause of that? See, antiphospholipid antibody syndrome, they'll give you the presence of antibody. Can anybody tell me what antibodies will be given in AMPLA? My screen is actually kind of lagging. Yeah. So they'll give you a case of recurrent abortions, okay? More than 10 weeks had happened and recurrent abortions were taking place. All right, they'll give you a history of recurrent abortions as well as anti-cardiolipin antibody. All right, what about factor 5? Now, this is the most common genetic mutation. But here, because the patient was ambulating for the first time, okay, after being bedridden, this must be a deep vein thrombosis. Okay, this must be a deep vein thrombus. Okay, very good. So these are the things that are very, very important. The different kinds of emboli for your exam that you need to remember. Pulmonary emboli. So as you can see, this is nothing but your saddle emboli. Okay, saddle emboli. Okay, this is your saddle emboli. All right, investigation of choice has been asked in your exam. Remember, it is CT, pulmonary angiography, right? There is an emboli present at the bifurcation of pulmonary vessels and can lead to sudden cardiac deaths. Okay, good evening, good evening. What about fat emboli? Again, this is a previous year question. Remember, they'll give you a history of an RTA, a road traffic accident, and they'll tell you after 72 hours, sudden dyspnea happened, and this patient died because of that. Remember, coma, like CNS abnormalities can be seen within 8 hours. Okay, within 8 hours. Very, very important. And thrombocytopenia results in a petechial crash. Air embolism. Now, this is associated with deep sea diving, right? So because of that, you can have vents where there are gas bubbles, nitrogen gas bubbles in the joints, or chokes where because the patient is choking, right? He'll be in a choking position, right? So these are the two things in sea divers that you need to remember. Yeah, GERD criteria. Very nice, very nice. And amniotic fluid emboli. This table, please go through them. Very, very important. I'm sure one of them will definitely come for the exam. Now look at this question. A 25-year-old man with a fever and a chronic cough has a 0.1 ml injection of a liquid containing. Basically, what test is this? This is your Montauk's or tuberculin test. Okay? Or tuberculin test. And as you can see, what has happened? We had put the PPD here, and we had put a circle around it. And we are doing this test to check any previous exposure to TB, right? Previous exposure to TB. If there was any previous exposure, this inflammation would have gone outside. So this is most likely a negative test, right? Negative test, meaning the patient had no previous exposure. Okay? If this patient had a exposure prior, right? This inflammation would have crossed this circle. Okay? Because your body recognizes the bacilli. Now, this is which kind of hypersensitivity. Remember, this is cell-mediated hypersensitivity. Okay, cell-mediated hypersensitivity. It takes around 42 to 72 hours for the cells to become active. And that's why it is also known as delayed type of hypersensitivity. Okay, what about antibody-mediated? This is also known as cytotoxic, because one of the mechanism is antibody-dependent cellular cytotoxicity, right? ADCC. That's why it is also known as cytotoxic. Yeah, humoral. You can also call it humoral, where antibody goes and destroys the antigen, the fixed antigen. What about immune complex? This is type 3. And type 1 is IgE mediated. Okay, IgE mediated. All right. Now, remember, these are the different types of hypersensitivities. Go through the mechanisms. All of them are important, and the clinical examples. Okay, out of this, bronchial asthma, definitely they'll ask you about, or allergies. One more thing to remember, contact dermatitis is type 4, while atopic dermatitis is type 1. If they ever say atopic dermatitis, remember, atopic dermatitis is type 1, while contact dermatitis is type 4. This was a question that was asked. Remember this, the most common cause in India is detergent or metals like nickel. Okay, so it affects females most commonly, nickel because of artificial jewelry, right? And these are all the other examples. So here, what is the difference? There is a fixed antigen here. Okay, so you see all these examples. There are fixed antigens here. Very, very, very important examples. Please go through them. Also remember your Graves' disease, yeah, myasthenia gravis. In the options, if they ask you, this is a type 5 hypersensitivity. Okay, if type 5 is given, choose type 5 rather than type 2. All right, let's look at the next question. So the answer is already given, but can somebody tell me the diagnosis of this? A butterfly-shaped rash. There is positive anti-nuclear antibodies and anti-dsDNA antibodies. Renal biopsy shows the deposition of immune complexes. So most likely a type 3 hypersensitivity. Right? So what is the diagnosis? Yes, we are talking about SLE. And what do you see here? You see lupus nephritis, that is seen in SLE, because there is immune complex deposition in the glomeruli. What about lupus pernio? Lupus pernio, guys? Lupus pernios? Yes. Lupus nephritis, you see wire loop lesions. Wire loop lesions, right? Very famous wire loop lesions. Lupus pernio is seen in sarcoidosis. Okay, it is a skin manifestation of sarcoidosis. Sarcoidosis, if you remember, it is also a systemic condition that affects the lungs most commonly, but it can affect the skin also, right? It can affect the skin also. Now, what is the mechanism? You know, your SLE has type 3 hypersensitivity. And you see, these are the clinical features because of the immune complex depositing. This is the most famous mala rash, which spares. Okay, remember, it spares the nasolabial folds. Okay, very, very important. This is your chronic cutaneous lupus that is, what do you say, discoid shaped. The rash is discoid shaped. Okay. What about the antibodies? Very important to remember. Anti-nuclear antibodies are the most sensitive antibodies, but as you can see, they're seen in scleroderma, or they are seen in Sjogren syndrome. So they are not specific to SLE. What is the most specific antibody? Anti-Smith antibody and anti-double-stranded DNA antibody. Both of them are specific for SLE. Okay, one more. Your anti-Rho, anti-La is associated with Sjogren syndrome. If you remember Sjogren, this is dry eyes, dry mouth. Also known as Zika, right? Because there is destruction of the salivary gland and the lacrimal gland in the eyes. That's why there is dry eyes and dry mouth. What about your anti-histone antibody? drug-induced lupus. So you must remember the mnemonic SHIP. Sulfonamide. What are the drugs? Sulfonamide, hydralazine, which is also the drug of choice for hypertensive emergencies. Okay, remember this very important question. Isoniazid, which is a drug given in TB, and procainamide. Okay, very good. What about sarcoidosis? See, again, I told you it is a systemic disorder. How do we diagnose it? You might have already seen, I've already told you, it is characterized by non-caseating granuloma, also known as the very famous naked granuloma, because there is no rim, okay? No rim of lymphocytes. How do you diagnose it? There are increased level of ACE, okay? The calcification that you see here is metastatic and an elevated CD4 to CD8 ratio. CD4 to CD8 ratio, where is it decreased? It is decreased in HIV. Okay, remember this. It is decreased in HIV. It is increased in sarcoidosis. All right. Yes, there is also test, but this test is not done anymore in sarcoidosis. Also, what do you see? You see this asteroid bodies. See, this is the giant cell. Inside that cell, you see these asteroid bodies. So intracellularly, asteroid bodies are seen with naked granuloma, and asteroid bodies are seen somewhere else also. Can somebody recall it for me? Where else do we see asteroid bodies? Where else do we see asteroid bodies? Can anybody recall it for me? Asteroid bodies are also seen in extracellularly, right? Asteroid bodies. I'm just going to write here. Asteroid bodies are seen in sporotrichosis. Yes, very good. Sporotrichosis. Okay, sporotrichosis, a dimorphic fungi, right? Causes sporotrichosis on, it's very common in Valentine's Day because of thorn prick. Okay, thorn prick. Thorn prick, right? Also remember that the kind of lesions that you see follow the lymph nodes. So there is a linear pattern of the lesions here, right? Yes, it is also known as Rose-Gardner's disease. Now, what about this body? This is with calcium with calcium in it. This is your Schaumann bodies, and the kind of lymphadenopathy that is very much associated with your sarcoidosis is your hilar lymphadenopathy. This is the lupus pernio. As you can see on the nose, you can see this rash, right? It involves the nasolabial folds, okay? It involves the nasolabial folds. So this becomes a differential diagnosis for you. Okay, this becomes a differential diagnosis for you. Also, yes, on gallium scan. So just for completion, on gallium scan, you see the very famous panda sign. Okay, panda sign. Where else do you see panda sign? You tell me that also. Where else do you see panda sign? So panda sign is also seen in Wilson's disease, if you can remember, right? And these are your antibodies, very, very important for the exam. Just have a quick overview, okay? Quick overview of all the antibodies that are autoantibodies that are important for the exam. Okay? Okay. Now let's look at the next question. A 70-year-old man presents to the oncology clinic with complaints of persistent bone pain, lower back pain, ribs, experience unintentional weight loss, definitely leading towards some kind of malignancy. There is hypercalcemia, anemia, elevated serum proteins, and the presence of M proteins. Very good. And you see a very characteristic, yes. What skull is this? This is your raindrop skull. And what are they talking about? They are talking about multiple myeloma. And you can see that multiple myeloma, there's a mnemonic for that. There's an absence of, actually what happens here, there's a defect in the in the light chains of gamma globulins, right? So you have a lot of plasma cells making a lot of antibodies, but they have only light chains present, right? No heavy chains are there. And because of that, one mnemonic for this is the crab mnemonic, where you see hypercalcemia. Why do you see hypercalcemia? Because bone is getting resorbed, right? There is renal failure and there is anemia. Because of renal failure, there will be a decrease in erythropoietin leading to anemia and your bony lytic lesions. Okay, so this is seen in multiple myeloma. Very, very important topic for the exam. Okay, very, very important topic for the exam. So this, what about your options? Hyperparathyroidism. Most common cause of primary hyperparathyroidism is parathyroid adenoma. Osteoporosis. So I have short notes for this. Just go through them. While the skulls, this is a raindrop skull. What about your cotton wool skull? Where do you see the different types of skulls that we have? Cotton wool skull. Where is cotton wool skull seen? Can anybody tell me this? Can anybody tell me this? Cotton wool skull. What about your, yes, this is seen in Paget's disease. Paget's disease. Very good. What about your hyperparathyroidism? That shows you a salt and pepper skull. Salt and pepper skull. Okay, salt and pepper skull. Any other skull that you remember? Any other skull that you remember? Salt and pepper, your cotton wool, your raindrop skull. And is there any other skull? What about thalassemia? Thalassemia and sickle cell anemia. Yes, geographical skull. Skull. This is seen in Langerhans histiocytosis. Okay, and thalassemia shows you hair on end appearance. Okay, very good, guys. Yeah, the hair on end or crew cut appearance of skull, because there is extra medullary erythropoiesis, right? Yes, very good, very good. Now these are the different, you can see the rouleau formation or the stacking of points. These are the different things that have been asked in your multiple myeloma. So let's just quickly go through them. Which cells are these? These where you have inclusions, immunoglobulins. See, this is a plasma cell because the nucleus is eccentric, right? And you have the inclusions, these immunoglobulins in the cytoplasm. These are the Russell bodies. Russell bodies. What about these cells? See, you have the inclusions in the nucleus. So this nucleus inclusions, these are your Dutcher bodies. Okay, your Dutcher bodies. Then you have this grape, like the whole cytoplasm is filled with immunoglobulins. This is your Mott cell. Also, on what is this? On electrophoresis, you will be able to see a gamma spike, right? Increase in gamma, right? Yes, very good. Very, very important. Plus, this is the final cell. That is the flame cell. Very good, guys. Very good. Okay. Yeah, gamma spike, M spike. Yes. Now, hyperparathyroidism, as you can see, this is a salt, your adenoma of the parathyroid. That is the most common cause. Secondary hyperthyroidism presents with hypocalcemia. Okay, so it occurs in renal failure and all those things. What about manifestations? Very, very important. They'll give you a clinical case telling you that this patient is feeling depressed and has stomach pain and there are renal stones plus the bone. They'll involve all this, okay, in hyperparathyroidism. So one pathognomic sign is the resorption on the radial side, subperiosteal resorption on the radial side, right? This is pathognomic, very, very important. Plus you see this rugger jersey spine where the middle part is resorbed, while in contrast to that, the end plates are seen very, very, very contrastingly, right? So that is known as rugged jersey spine. Paget's disease, you have three phases, right? Lytic, mixed, and blastic. In the lytic phase, you see this blade of grass appearance, okay? Also known as flame shape. So I'll draw a candle here. This is the flame-shaped resorption of the bone. You can also see osteoporosis circumscripta, where there is like whitewashing. The resorption is taken from the starting till the end, right? What about your mixed phase? You have this very famous vertebra. What is this vertebra? Picture frame vertebra. And you have this ivory vertebra, the whole of it. And this is a dysfunction of what Paget's disease happened because of an abnormal activity of osteoclast. Okay? Abnormal activity of osteoclast. Finally, you have this diploploic swelling or the cotton wool skull also. Okay? Cotton wool skull that is seen here. And you have this skull, which is the Tom O'Shanter skull in the blastic phase. Okay? Osteoporosis, one very, very important image is the fish mouth vertebrae. Okay, because of the weakness, the vertebrae starts. Yes, guys, yes. So, can anybody tell me fish mouth is also associated with some or buttonhole appearance? Fish mouth appearance or buttonhole appearance is associated with chronic mitral stenosis, right? It is associated with mitral stenosis in RHD. Remember, yes, very good, very good. Now look at the next question. A 55-year-old man undergoes a kidney transplant. Within hours of the surgery, the graft becomes swollen, mottled, and fails to produce urine. So what kind of graft rejection is this? Guys, this is happening within hours. Okay, within hours. Very important point to note that this is happening within hours. So if this is happening within hours, the most important graft rejection is hyperacute. Okay, and this happens because of preformed antibodies against the donor cells. Yes, very good. T cell mediated, your donor T cell is seen in graft versus host disease. So there's this table, just go through this. Within 48 hours, if the graft rejection happens, it is hyperacute. What about acute? It takes around days to weeks, even less than 6 months. Okay? More than 6 months is known as chronic, or months to years. And graft versus host disease is variable, but the T cells that are involved is donor. Okay? T cells that are involved are donor. What are the different types of graft that you have? And this graft rejection is seen in allograft. Okay? Allograft. What is an allograft? Can anybody tell me? This is a graft that is seen in the same species. What about xenograft? Xenograft is when there are different species. Okay, different species. Isograft is between twins. I'm just going to put it here. Isograft is twins. And auto is self. Very good, guys. Very good. Yes, the twins that you have here are monozygotic or identical. Okay, identical. Chalo, let's look at the next question. A 22-year-old man presents with tall stature, long limbs, cardiovascular abnormalities, including mitral valve prolapse. The patient exhibits ectopia lentis, but does not have intellectual disability or thrombosis. So before you tell me the diagnosis, first tell me the diagnosis and also tell me what can you rule out here. Very good, Bhavana. Very good, very good. Okay, what can you rule out here? What is the diagnosis? First, diagnosis is Marfan. But what can you rule out? What can you rule out and why can you rule that out? You can rule out because there is no intellectual disability, you can rule out homocystinuria. Homocystinuria. Okay, remember homocystinuria also has morphinoid features, and there are the patient will be tall and with long limbs, but the ectopia lentis, the dislocation of the lens will be, can anybody tell me how will be the dislocation of the lens? It will be inferonasal. Okay, dislocation of the lens will be inferonasal. There will be decrease in IQ, okay, intellectual disability. There can be thrombus formation or myocardial infarction. So all these features are seen, okay? And treatment is with vitamin B6, B12, B9, okay? Treatment is with all these 3 vitamins. Okay? And what is the defect in homocystinuria? Can anybody tell me the defect? Can anybody tell me the defect of homocystinuria? What is the defect? What is the defect, guys? Can anybody tell me the defect? This is due to a defect of cystathionine. Sorry. Cystathionine beta synthase. Please remember this. What about the ectopia lentis of Marfan's? Remember, it is superotemporal. Okay, superotemporal. Very, very important. Mitral valve prolapse is the most common cardiac manifestation that is seen in your Marfan syndrome. And Marfan is an X-linked, it is an autosomal dominant condition. Okay, autosomal dominant condition. Again, you can see this is the ectopia lentis and this is superotemporal. What is a gene defect? Fibrillin 1 gene defect. Okay, 1 gene defect. Very, very important. All right, that's what. And these are the features that you see in Marfan syndrome. Arachnodactyly, spider-like fingers, retinal detachment. Aortic dissection is the most common cause of death. Okay, and the most common heart defect is mitral valve prolapse. This is the most common heart defect. All right. Now, these are your, autosomal dominant disorders. All of them are very important for the exam. So what I do usually whenever you have an exam, right, look at this table and try to recall whatever you've learned about all the disorders from different chapters, from different subjects. Like if I give you an example of dystrophia myotonica, osteogenesis imperfecta. Osteogenesis imperfecta presents with the triad, right? There is SNHL, there is, what do you say? There is blue sclera, and there are multiple bony fractures. Multiple fractures. This is a collagen type 1 defect. Right? Collagen type 1 defect. From collagen, try to remember all the types of collagen that you have. Go to anatomy, then go back to the defects. Collagen type 4 defect is Alport syndrome, right? And if you talk about your Marfan syndrome, we have just covered Marfan. NF1, NF2, very, very important for the exam. Achondroplasia is decreased in, it's a kind of short stature, right? Noonan is the male variant of Turner syndrome. Okay, Noonan is the male variant of Turner syndrome. And Noonan has a decrease in IQ. Okay, IQ is affected. IQ is affected, while in Turner syndrome, IQ is normal. Okay, IQ is affected. IQ is decreased, while Turner syndrome, there is normal IQ. Turner syndrome, if you can recall, it is actually there is a loss of one X chromosome. So you have all these, there is, what do you say? Estrogen is affected because of streaky ovaries, right? I hope you're able to recall this. So all the features that you see, all the secondary sexual characters are lost, and all the features that you see, there's a short female with webbed neck and a shield-shaped chest with wide space nipples. All those, try to recall them. Tuberous sclerosis, also known as bone-will disease, 𝗏𝗄1 and 𝗏𝗄2 gene defect, right? It causes, there's hypopigmentation that is known as ash-leaf macule, right? Also, there are, what else do you remember? What else do you remember about that? I hope you're able to recall them. FAP. FAP is familial adenomatous polyposis, and there are more than 100 polyps, right? More than 100 polyps that you see. Yes, very good, very good. Huntington's disease is CAG repeats. Anyway, we are going towards that only. Angiomyolipoma, very good for tuberous sclerosis. I'm sorry. What about your autosomal recessive? These are also conditions very, very important for your exam. If you remember, alkaptonuria, homogentisic acid hydroxylase defect, right? Alpha-1 antitrypsin deficiency, pan-acyner, emphysema. Albinism is a previous year question. Please remember, it has been asked previously. Okay? So all these are very, very important for the exam. Musty odor, phenylketonuria, phenylalanine hydroxylase, musty odor. Okay? What about all this? A-gamma-globulinemia we have just discussed. Fragile X syndrome, Wiscott-Aldrich. Wiscott-Aldrich also has a triad. Okay? So there is thrombocytopenia. Thrombocytopenia. There is eczema and recurrent infections. Right? Yes, please try to recall this. Again, this was a defect in WASP gene. So the only place where you have small platelets, right? Then these are mitochondrial disorders. Out of that, Milas is the one that they commonly give, right? Mitochondrial DNA, mother to all, father to none. And these are all your, pedigree. 1 minute before the exam, just go through all the pedigree charts. Whatever is important is written just below the pedigree charts. Okay? Now look at the next question. There is a 7-year-old boy with intellectual disability, hyperactivity, long face with large ears. CGG repeats in FMR1 gene. So remember Fragile X syndrome. So you know the answer already. This is Fragile X syndrome. What are the repeats? CGG repeats. Okay. And because of that, there is a defect in FMR1 gene. Okay. This is located on the X chromosome, right? This is nothing but Fragile X mental retardation gene, right? So once this is affected, remember this is the second most common cause of intellectual disability. I hope you remember this. And the clinical features, you draw there is a boy with a large mandible, okay? So there's a boy with a large mandible, okay? This is the boy with the large mandible with elongated ears, and he has very big testes, okay? So macroorchidism, large ears, and large mandible. These are the clinical features of your Fragile X syndrome. What about Huntington's disease? So this affects the caudate nucleus, right? There are CAG repeats in the axons. So it is also known as hunting in the cage. Myotonic dystrophy shows you CTG repeats. Friedreich's ataxia shows you GAA repeats. Okay. So these are given here. Just go through them. Yes, very good. What about this one, guys? Spontaneous abortions. There is a translocation between chromosome 14 and 21. So most likely, see, 14 and 21 are acrosomes. So there is a translocation between acrosomes known as Robertsonian translocation. Okay, Robertsonian translocation. right? Between the acrosomes, right. And this is seen in Down syndrome. But the most common cause of Down syndrome is because of maternal Can anybody tell me the most common cause? Is it Robertsonian translocation? Turner syndrome is 45XO. This is a kind of monosomy we just discussed, right? What about Patao? Patao, 13 साल की लड़की को नहीं पटाना है. So this is actually trisomy 13. Trisomy 13. What about Edward? It is a trisomy 20, trisomy 18. Right. Yes, maternal. Yes, maternal advanced age is a risk factor. Yes, right, you're right. So these are some important things about Down syndrome that you need to remember. Most common form of leukemia involved in Down syndrome is ALL, and most specific. Remember, AML M7 is very specific to Down syndrome, right? This is the most common cause of intellectual disability, and maternal meiotic disjunction is the most common cause, right? Because of increased maternal age. And you see this all images where there is sandal toe. You have your mongoloid faces. You can see there is micronathia, where the chin is small and the tongue is out, right? Tongue is big, macroglossia. You see this, which is the Simeon's crease. Okay? Simeon's crease, right? And then you see this brush field spots. In the iris, you see these spots, which are known as brush field spots. Okay? Edward and Patao, if you see karyotyping done at metaphase, very, very important. What is this? If you can see, this must be Edward, trisomy 18. Then you have trisomy 21, which is Down, and trisomy 13, which is Patao. Okay? Look at the next question. Which of the following is known carcinogen linked to hepatocellular carcinoma? Which of the following is a known carcinogen linked to hepatocellular carcinoma? So hepatocellular carcinoma is linked with aflatoxin. Okay, aflatoxin. Remember, aflatoxin, you get it from aspergillus in the groundnuts. In PSM, you must have learned groundnuts. There can be aspergillosis, which have this toxin, which is your aflatoxin. Okay, which can cause 𝗏𝗔𝐶. And 𝗏𝗔𝐶, if you remember, it increases AFP. So this is a whole line. In one line, you can learn about it. पेपर लीक करवा दो. वेरी गुड. यही करते बैठते हैं हम लोग, ठीक है? यही करते बैठते हैं. Remember about aflatoxin? It causes hepatocellular carcinoma and increases the level of AFP. Okay, groundnuts याद रखना, aspergillosis. ठीक है? तुम एग्जाम दे दो. How you guys, you're very close to the exam. तो अभी तो I'm just revising you. Today is what, 3? You must already know all this. You must already know all this, right? I'm just discussing, trying to revise whatever you already know. Because you're so good in patho, right? All of you are so good in patho. What about the asbestosis? Remember, the most specific cancer associated with asbestosis is, what is the most specific? It is mesothelioma. Mesothelioma. What about the most common? Most common is adenocarcinoma. Yes, most common is adenocarcinoma. What about arsenic? Arsenic and vinyl both cause angiosarcoma of liver. Okay, angiosarcoma of liver. There are so many carcinogens, and this is a very expected question. So go through this table, all of the things that are required, all your carcinogens, chemical carcinogens, as well as your biological carcinogens are given below. Some of them are clinical questions, previous year clinical question. Out of that, EBV, please put a star mark. It's very, very important. And nasopharyngeal carcinoma, there cannot be an ENT paper without NPC. Okay, so this was a saying of a faculty of ENT. There cannot be a FMG paper without NPC. So remember, EBV is very important. HPV we have just discussed, right? HPV we have just discussed. What about the rest? Just go through them. Very important for the exam. Yes, Bhavna, very good. Look at this now. Which of the following mutated oncogenes produce products may serve as a tumor antigen? So they have spoken about oncogenes, right? Oncogenes, and they've asked them as which of the following will serve as a tumor antigen. Out of all three, RAS is an oncogene, BCR-ABL are oncogenes, and remember, they increase the tyrosine kinase. This fusion increases tyrosine kinase, and this fusion is seen in CML. Where is this fusion? On the chromosome 22. Please remember this. These are important for questions. Chromosome 22, also known as Philadelphia chromosome. Okay? So what is the answer in this? D has to be the answer because P53 is actually a tumor suppressor gene. Okay, P53 is a tumor suppressor gene. I hope you are able to recall that. What about your oncogenes? We have 5 types of oncogenes. You have growth factors, then you have growth factor receptors. Very, very important, and this is HER2/neu. Adenocarcinoma has been asked even in this INESET exam. Adenocarcinoma was asked of lung. Okay, red gene medullary carcinoma associated with MEN2A, 2B. Okay, amyloid-A-Cal. Okay, again, this was an INESET question. Medullary carcinoma was an INESET question. Very important. Okay, A-Cal. This is a gain of function of red gene. Loss of function of red gene causes Hirschsprung's disease. All right, ALK gene. Again, adenocarcinoma. Very important. Anaplastic lymphoma, neuroblastoma. Okay, KIT causes GIST. What about signal transduction protein? KRAS is associated with pancreas, your colon, pancreas, and lung. Okay. What about HRAS? HRAS, can anybody tell me HRAS? HRAS, NRAS. BRAF is with hairy cell leukemia. What about HRAS? Somebody tell me about HRAS. Somebody tell me about HRAS. What about HRAS? HRAS is bladder and kidney. And N for M, it is associated with AML as well as melanoma. Okay? 𝗲𝗵, very, very famous. Put a star mark. Direct one-liner comes in this. 𝗲𝗵 is associated with Burkitt's lymphoma. Okay, it is a non-Hodgkin lymphoma. All right. Yeah, Burkitt. Yes. Very good, Bhavna. Very good. Burkitt's lymphoma. NMIC is N for N. Neuroblastoma. LMIC is small cell lung carcinoma. Okay, very, very important. Please go through them. Very important questions for the exam. What about your tumor suppressor genes? You have your RB, P53, RB, very famous. Retinoblastoma. Last time there was a question given with the image of the child where there is leukocoria seen. It causes retinoblastoma or osteosarcoma, right? Then P53, most human cancers, like all, including your CA, lung, head and neck, colon, breast, okay? Plus a P53 leaf from any syndrome that is also associated with P53, okay? APC, CA colon, right? BRCA1, it is breast and ovary. VHL is renal cell carcinoma. WT1, it is associated with Wilms. What about NF1 and NF2? Neurofibromatosis, again, very, very important for the exam. CDH1, 𝗵𝗂𝗃. Remember, it affects 𝗵𝗂𝗃. This was a direct question. It affects lobular breast cancer, where you have the Indian file pattern, and stomach. STK11, remember Peutz-Jeghers syndrome? 11-year-old child, STK11, you have hematomatous polyps as well as melanosis, hyperpigmentation of the oral, perioral hyperpigmentation. I hope you're able to recall. ये सब याद आ रहा है? Peutz-Jeghers का याद आ रहा है? STK11. Okay, you have hematomatous polyps. And this perioral melanosis is very famous image, right? Perioral melanosis. Very famous. ठीक है? P10, remember it is cow den, and cow den, बस इतना ही याद रखना, this one line. Chromosome 10. Polyps, there are polyps, breast cancer, thyroid cancer, and endometrial cancers. Okay? Yes, arborizing pattern. Very good, guys. Very good. What about this? Now, I have already told you about this. Amyloid, spindle-shaped, thyroid nodule. So most likely talking about medullary thyroid carcinoma. See, papillary is the most common. All of them are radiosensitive, right? All of them are radiosensitive, associated with radiation, out of which papillary is the most common. It shows you the presence of samoma bodies, dystrophic calcification, okay, the Wolin, all right? Plus you see orphan Annie eye nuclei. Okay, plus also coffee bean appearance of the nuclei. Okay, follicular, remember one thing about follicular, it has capsular invasion. Okay, capsular invasion. All of this happens in the follicular cells, right? All of them happen in follicular cell except for medullary cancer, which happens in the parafollicular C cells. Okay, parafollicular C cells. So capsular invasion is seen. That's why FNEC is not useful, because you cannot differentiate between follicular adenoma and thyroid carcinoma, right? Very good, Raghu. Very good, very good. Anaplastic, the only thing you remember about anaplastic is A for A. It is the most aggressive. Okay, the most aggressive. Let me show you some images. This is the orphan eye nuclei, which has a glass shaped the nucleus. Okay, what about this? This is the coffee bean nuclei. Here you can see this is parafollicular C cells, medullary carcinoma, capsular invasion. The tumor cells are crossing the capsule, while this is your follicular carcinoma, right? And when you talk about amyloid A-cal, the deposition is seen in medullary carcinoma. What is the marker? Calcitonin. What is the gene defected? Red gene. Okay. Worst prognosis definitely is your anaplastic. Okay. Let's go to the next question. So just by looking at this, can you tell me which one is this? This is used, I think all of you have used this. This is used in yes, this is your EDTA. Okay, EDTA, the purple vacuum thinner. It is used for complete blood count, and this is actually your EDTA. Okay, the Okay, this is EDTA. Heparin is used, the vacutainer is green in color. Okay, green in color. Yes, there is no, yes. Okay. Hi, Mohammed. Hello. Hi. NaF, sodium fluoride, actually inhibits. So this is glucose, right? It inhibits the cycle, the glycolysis. That's why this is used for glucose testing. Okay. And trisodium citrate, this is used for coagulation study. This is a blue vacutainer. Blue vacutainer. Okay, blue vacutainer. So blue, your sodium fluoride, remember this is gray. G for glucose, G for gray. Or hara, hara is heparin. Green is heparin. So these are the different kinds. You have your clot activator. This has been asked. Clot activator. There are no clot. Okay. Nothing, no anticoagulant in this one. Okay. Sodium fluoride is gray. Purple is the most common, which is EDTA. 3.2% sodium citrate is used for coagulation studies, while green is heparin. Okay. Now look at this next question and try to answer. A 22-year-old female presents with fatigue and pallor. Lab tests reveal hemoglobin of 10, so definitely anemic. And this must be microcytic because MCV is 66, MCH is 28. Okay, and RDW is also in the normal range. All right. So what do you see? RDW is the normal range, and RBC count is the normal is 5. Okay, around 5 million. So this is 6 million. So can anybody tell me, is this for, what is the diagnosis? Can anybody tell me what is the diagnosis? What do you think is the diagnosis? What do you think is the diagnosis? So guys, if this was iron deficiency anemia, the RBC count should have decreased. The RDW should be high, because RDW, iron deficiency anemia, shows you high increase in RDW. RDW is normal here, right? 14.5 to how much is normal, guys? Do you remember? So what is the diagnosis here? This must be beta thalassemia trait. Why is this beta thalassemia trait? I'll tell you. What is Menzel's index? Can anybody recall what is Menzel's index? MCV upon RBC. What is the MCV here? 66. What is the RBC here? 6. That gives you 11. Okay. So remember, this is less than 13. This is less than 13. Iron deficiency anemia is supposed to be more than 13. Less than 13 is seen in thalassemia. So this must be beta thalassemia trait. And for that, you will check the HbA2 levels. Okay, this was a recent INE-set question. Very important. Just try to recall. D-dimers, you can check for DIC. Ferritin for iron deficiency anemia. Remember, this is the most sensitive marker for iron deficiency anemia. So how do you differentiate between the two? Menzel's index is more than 13, while here Menzel's index is less, right? HbA2, when you check the HbA2 levels, remember they should be always more than 3.5% in beta thalassemia trait, while this should not elevate in iron deficiency anemia. And RBC are less, while RBC are more here, right? Iron profile, it is abnormal in iron deficiency anemia, of course, but it is normal here in beta thalassemia trait. Okay. Why is it beta thalassemia trait? Look at the RBCs. Again, RBCs are normal. RDW is normal. And if you check the Menzel's index, it gives you 11, which is less than 13. Okay. Just because they give you a 25-year-old, look at all this. MCV should be low. In anemia, iron deficiency anemia, you should have decrease in iron, serum iron, transferrin saturation, ferritin. TIBC should increase. Remember, TIBC increases here. Okay. You see pencil cells. Let me show you the cells. See, RDW is increased because there is a difference in shape and size. Look at the nucleus of the lymphocyte. Compared to that, if you compare the RBCs, what is the shape? The shape is smaller. So this is microcytic anemia. Okay, microcytic. What has happened to the hemoglobin? Is it decreased or increased? Why do I call it hypochromic? Because look at the central. Yes, so this is hypochromic. Okay, hypochromic. And also you see these cells, right? These cells are the pencil cells. So you also see poikilocytosis, right? And a change, variation in shape, which is poikilocytosis, while a change in variation in size, which is anisocytosis. So both are seen in iron deficiency anemia. So because of that, RDW should actually increase, while in thalassemia trait, it is normal. Look at the question again. RDW was normal here. Okay? RDW was normal here. Again, in this iron deficiency anemia, you see this very characteristic nails where the center is pushed down while the edges are elevated. This is known as 𝗏𝗏. Okay, which is also known as spoon-shaped nails. One time in the exam only this image was given. And iron deficiency anemia, can anybody recall a syndrome that has 𝗏𝗏, iron deficiency anemia, esophageal webs, and one more? Can somebody recall that syndrome for me? Do you remember Plummer-Vinson syndrome? Can you tell me the triad of Plummer-Vinson syndrome? You have iron deficiency anemia, you have esophageal webs, and very good, dysphagia. Dysphagia because of the esophageal webs, and tell me one more. Okay, esophageal webs, iron deficiency anemia. Yes, it is also known as Patterson-Kelly-Brown syndrome. Yes, 𝗏𝗏. So all these are findings. And this question where iron was, decrease in iron absorption, this question was asked in your Jan 2020. 4 question. Okay? Very good. Okay. Go through this table. Very important for the exam. And as you can see, thalassemia shows you the presence of target cells. Target cells, you have these faces, which are known as chipmunk faces. Okay, chipmunk faces. And you have this crew-cut appearance. That is also seen in sickle cell anemia. Okay, crew-cut. Let's look at the next question. Let's look at the next question. You have a 10-year-old boy with jaundice, splenomegaly, and pallor. This itself is a triad here, guys. This is a triad. And osmotic fragility is positive. The peripheral blood smear is given below, and the underlying mechanism involving a defect in which of the following proteins. So if you can remember, this is a hemolytic anemia. Hemolytic, and which kind? Extravascular. Okay, and this is the diagnosis here should be hereditary spherocytosis. As you can see, all these spheres, right? Microcytic spheres, where there is no. Yes, very good. So this happens because of a defect in ankyrin or spectrin. IgG antibodies are seen in immune hemolytic anemia. Okay, autoimmune hemolytic anemia. CD55 and CD59 defect is seen in PNH, paroxysmal nocturnal hemoglobinuria. Okay? I hope you're able to recall this. So these are some things that you need to go through before the exam. Look at the next question now. A 55-year-old man with chronic pancreatitis with fatigue and diarrhea, lab results hemoglobin of 10, MCV is 118. Now MCV, guys, normal MCVs is 80 to 100. Anything less than 80 is known as microcytic. Anything more than 100 is known as macrocytic. So the kind of anemia that they're talking about is macrocytic anemia. And one special form of macrocytic anemia is megaloblastic anemia, right? Megaloblastic anemia. Your megaloblastic anemia can present with the presence of this dot here with the DNA remnant, that is your 𝗲𝗿-𝗺𝗀 body. 𝗲𝗿-𝗺𝗀 body. Okay. What about this second thing? What are these? Very famous hypersegmented neutrophils. Hypersegmented neutrophils. What do you see here? Okay. What do you see here? You see a neutrophil which has more than 5 nuclear lobes. Like if you count 1, 2, 3, 4, 5, 6, 6 nuclear lobes are there. And this mitotic spindle, it can make a figure of 8. It can be a circle, any one of them. Arginine-rich mitotic spindle. What is this? What is this? This is a mitotic spindle. Okay? This is a mitotic spindle. Okay? This is a mitotic spindle. I hope you're able to see this. Figure of 8 is seen where? Where else? Yes, mitotic spindle, which is your Cabot ring. Okay, Cabot ring. So they have asked, which of the following do you see in macrocytic anemia, which is your megaloblastic anemia? So you see all three 𝗲𝗿-𝗺𝗀 bodies. Remember, 𝗲𝗿-𝗺𝗀 bodies are seen in megaloblastic anemia as well as cases of post-splenectomy. Okay? And this is your hypersegmented neutrophil. Very, very, very important with the presence of macroovalocytes. Okay? And Cabot rings. Figure of 8. Can anybody tell me figure of 8? Where do you see? Where do you see figure of 8? Heart. So these are your vitamin B complexes. Please go through them. Very important. Vitamins is that short topic that's 100% going to come in your exam because it integrates with so many subjects, right? So go through this. This is important. Now look at the next question. A 30-year-old woman presents with a 3-day history of heavy menstrual bleeding, spontaneous bruising, shortness of breath. She also repeats gum bleeding and blood in the urine. What else can you see? Hemoglobin is 7 because of the bleeding. The platelet count is 20,000. Guys, normal platelet count is around 4.5 lakhs. Okay, 1.5 to 4.5 lakhs. So the platelets are decreased. Here, PT is increased, APTT is increased, and peripheral smear shows large blast with ore rods. So, you know, ore rods are nothing but the fusion of primary granules of lysosomes. So this is nothing but your AML M3. And what is the diagnosis here? DIC. Okay, this is a patient that has undergone DIC, right? Yes, very good. And what is the translocation that you see in AML M3? Translocation 15-17. Translocation 12-21, where there is flipping, is seen in ALL. Okay, it is a good prognostic factor. Good prognostic factor. What about your inversion 16? This is seen in AML M4. Okay, and translocation 9-22, this is seen in CML. Okay, so I hope you remember your AML is classified into so many other types, right? Around 0 to because of the FAP classification, you have till M7, right? M7. And out of this, the most important that you need to remember, M2 is the translocation of 821. Okay, 821. What about translocation 822? 22. Can anybody tell me what is this translocation? Can anybody tell me what is this translocation? if you have not done some subject at this point, do the PYQs of that subject. Okay. Yes, translocation 822 is seen in Burkitt's. Okay. 821 is M2. All right. M3 is 15, translocation of 1517. Here you have the presence of DIC. Also, you have these crisscross rods. Okay. These are known as OR rods. All right. You have this myeloid cell with OR rods present, and this crisscrossing is also known as faggot cell. Faggot cell. Okay. M4 will show you the presence of gum bleeding and gum hypertrophy. Sometimes they just give you the image and ask you the question. Okay, gum hypertrophy or gum bleeding. If they tell you like that, remember it is M4 and it is associated with inversion 16. Okay, inversion 16. And this is actually when the leukemia goes inside the soft tissue, which is scleroma. Remember, it is associated strongly with M2. Okay, M2. What is the investigation of choice? Flow cytometry. Flow cytometry is the investigation of choice for this. Right? Now, when you talk about ALL is common in children, right? And they always ask you the prognostic factors, the good and the bad. So remember one, and the other one is bad. So 2 to 9 females, because females are better than males. Whites, because we are racist, right? L1. BALL, bacche, man ke achhe. Okay, so BALL, and remember this is a gene mutation of PAX5. While TALL, T cell ALL, is a mutation of Notch gene. Okay. Okay. Also, you have the presence of mediastinal mass. Okay. The involvement of tissue. Tissue involvement is there in TA, tissue infiltration, right? So you have mediastinal mass, the testis mass. So remember that is a finding of TALL. Testicular mass. Very important. Okay. So these are if they talk about ALL, they'll always give you a child. Okay, they'll give you a child. And remember, the blast should be more than 20%. The blast, because you are having immature cells here, right? Look at this question now. Look at this question now. A 65-year-old man presents with infections. What do you see here? What do you see here? You see that there are, look at this. These are RBC, and just compare the size of the RBCs with the lymphocytes. So this must be the lymphocytes. And because they are comparable to the RBC, they are mature lymphocytes. Okay, mature lymphocytes. So mature lymphocytes, either they are seen in, when we're talking about mature lymphocytes, this cannot be blastic, right? So this must be chronic lymphoid leukemia. Okay. And what do you see here? These are your parachute cells. So I'll draw a parachute here. See, this is the parachute cell or the smudge cells. Okay. Smudge cells. Yeah, parachute cells. And because they look alike, like all the cells, all these lymphocytes, okay, they look alike. This is also known as the very famous convent schoolgirl appearance. Okay. Remember, this patient is usually having no symptoms. All right. So remember, whenever we differentiate between chronic lymphoid leukemia, yeah, chronic lymphocytic leukemia, yeah, a chronic myeloid leukemia, remember that the differentiating factor is this is usually a patient that has no symptoms, usually asymptomatic. You see these cells. Okay, you see these cells that are there, that convent schoolgirl appearance, plus you see these lymphocytes are fragile, so they can break. When you're putting the slide, they can break and produce smudge cells, right? And the cytogenic variation shows deletion of 13q. Also remember, these are CD23 plus CD5 positive. That's why the investigation of choice will be flow cytometry. Okay, investigation of choice will be flow cytometry. So there will be splenomegaly, but when I say massive splenomegaly, which one do you think it is? If in the same question, like instead of this image, I show you another image and I ask in the question, massive splenomegaly, which one do you think it is? See, massive splenomegaly points towards CML, okay? CML. So remember, the investigation of choice is flow cytometry, and the markers, the most important markers that you need to remember is CD5 and CD23. They will be positive for sure. And CD5 positive, but CD23 negative, that is seen in mantle cell lymphoma. Okay, mantle cell lymphoma. What about your, CML? When we talk about CML, remember, you see the Philadelphia chromosome, translocation of translocation of 922. There is a fusion of BCR-ABL gene. Okay. The clinical feature from M, please remember from M that there is massive splenomegaly. Okay, massive splenomegaly. Or in the question, if they do not mention massive splenomegaly, they will tell you something about the patient is not able to eat. Okay. Splenomegaly. Very important. Okay? Plus, what do you see? You see so many types of cells, right? Different cells, because there is a proliferation of myeloid proliferation, right? All the cells that myeloid cells produce, they will proliferate. So you will have neutrophils, you will have platelets, increase in platelets, you will have increase in basophils. Very, very important. The blastic phase, do you remember phases? You have increase 20% increase. The accelerated phase will show you an increase of basophils, right? Accelerated phase. Rated phase. That will show you an increase, 20% increase in basophils. Okay. So remember, massive splenomegaly and Philadelphia chromosome. If I talk about CLL, convent, and this, because there are so many cells, it is known as garden party appearance, garden party या college girl appearance. ठीक है? Garden party या college girl appearance. ठीक है? So very, very important. Now look at the next question. This is actually a 5-year-old boy presents with weight loss, fever, and painless swelling in the area of his jaw. CBC reveals anemia and lymphocytosis. Biopsy finding from the swellings are seen in the image below. Which of the following is true in this patient? So most likely diagnosis. Can anybody tell me what is the diagnosis here? What is the diagnosis that you see here? Diagnosis is Burkitt's lymphoma. Okay, and Burkitt's lymphoma, you can see the starry sky. Okay, you can see the presence of a starry sky where you have macrophages that have engulfed these tumor cells and the sea of tumor cells. Okay, so all tumor cells and macrophages that have engulfed, those macrophages make the stars, and then the sky is made up of tumor cells, right? So all forms of the tumor cell are associated with MYC gene. Yes, which kind of MYC gene? c-MYC. Okay, c-MYC. Endemic are 100% infected with EBV. Remember, endemic affects the pediatrics. Okay, pediatric. You'll usually see the like clinical features involving the jaw and an African. Okay, African tumor. This tumor is highly aggressive. Okay, so it is malignant, and that's why it exhibits a high mitotic index, but BCL2, it does not show BCL2 positivity. BCL2 positivity is seen in follicular lymphoma. Okay, it is seen in follicular lymphoma. Translocation 14, 18. Okay, if you can remember this much about your follicular lymphoma, this is important. Okay, and this is a table, just go through quickly. Usually they don't ask other things, but Burkitt, your hairy cell leukemia, that is important. Okay, now look at this question. A 15-year-old male patient presents with cervical lymph node enlargement came to the OPD and the biopsy was examined, shows a cell given in the image. The cells are positive for CD20, LCA-EMA, okay? EMA, but they are negative for CD15 and 30. So you might know that the Hodgkin's lymphoma, they are all positive for your CD15 and 30. But then you have, yes, very good, very good. So what cell do you see here? You see a very classical Reed-Sternberg cell, which is the popcorn cell. Okay, the popcorn cell. And this is seen in non-Hodgkin's. Which type of non-Hodgkin's lymphoma? Nodular, lymphocytic predominant Hodgkin's lymphoma. These are all your classical type of Hodgkin's lymphoma. Okay, classical type. So Hodgkin's lymphoma mixed cellularity shows you the Reed-Sternberg, the classical Reed-Sternberg cell. What about lymphocytic predominant? So you can just, yes, very good, very good. Remember, this is also not associated to 𝗵𝗵. Okay, very good. Go through this one table. From here, there was a recent INESET question where they had asked about the lymph node involvement and Walde's ring was given. So this was important. So this is between Hodgkin's and non-Hodgkin's, the differences between them and the types of Hodgkin's lymphoma. Remember, the classical variety include your 4: nodular sclerosis, mixed cellularity, lymphocytic rich, and lymphocytic depleted. Okay, nodular sclerosis is the most common in the world. You have lacunar cells with clear spacing, and it can be or cannot be positive for 𝗵𝗵. But remember, there will be mediastinal mass. So in the question, they'll give, if they want to give you about nodular sclerosis, they'll mention mediastinal mass. Okay, the involvement of mediastinum. So N for M. Okay, mediastinal mass will be seen, and all of them will be CD15 and CD30 positive, except for nodular lymphocytic predominant. It is not associated with 𝗵𝗵. It is having the best prognosis overall, and it has CD20, BCL6, EMA, CD45 positivity. Just remember CD30 and 15 negative. Okay, CD13 and thank you, Hanuman. Thank you. Really happy to see you too. All right. So these are the different types that you need to remember and very important for the exam. Let's look at the last 2 questions. Look at this question. A 10-year-old boy has easy bruising and frequent nosebleeds. His labs show a prolonged bleeding time. So platelets are affected. Platelets affected. BT, if your BT is increased, means platelets are affected. And what do you see? There is decreased platelet aggregation and prolonged APTT. Now, prolonged APTT means intrinsic factors are affected. Okay, intrinsic factors. Some kind of intrinsic factor are affected. So this must be, it cannot be hemophilia A, because hemophilia A is a factor deficiency of, can anybody tell me which factor deficiency? Hemophilia A. A is a deficiency of factor. Which clotting factor? 8. So I always say A8. Okay, 8. So it will only increase APTT levels. Okay, it will only prolong the APTT. It has no effect, no problems with the platelet, right? It will only affect the clotting factor. What about Glanzmann's thrombasthenia? Again, this will increase the bleeding time only. Why? Because this is a defect in the glycoprotein 1B9. Okay, 1B9. All right. What about, I'm sorry, for your Bernard syndrome? What about your Glanzmann? Glanzmann is glycoprotein 2B3A. Okay, this Glanzmann affects 2B3A, while Bernard-Soulier, you have big platelets where you have a defect in 1B9. All right, 1B line. So both of them actually only increase the BT levels, but there is no thrombocytopenia. There's only increase in BT levels. While von Willebrand factor disease, this is the disease that affects both the APTT as well as BT. Okay, because platelet aggregation, okay, platelet addition involves 1p9 with von Willebrand factor, okay, on the endothelium, right? Do you remember? Okay, so defects in platelets will increase the bleeding time, while defect with clotting factors will increase the PT as well as APTT. So just go through this one table. This one table is very, very important for your exam. Yes, 2B3A. Okay, 2B3A. So this one table, everything that is important for the exam, everything that you need to remember is given in this table. Just go through this. It's important. Okay? Now, hemophilia A and B, remember the treatment has been a question in INI-set. The treatment has been questioned in INI-set. Remember, both of them will increase the APTT levels. This is a defect in 8, while this is a defect in factor 9. Okay, so they increase APTT. How do you treat it? A, you give cryoprecipitate. It ends with 8, right? Cryoprecipitate, while fresh frozen plasma is given for hemophilia B. Okay? Hemophilia C is the only one which is autosomal recessive. Everything else is X-linked recessive. And this is a factor 11 deficiency. Look at the last question. There's a 3-year-old child that has been brought to the hospital with complaints of fever, rash, swelling of the hands and feet since past 5 days. Okay? This rash, there is edema of hands and feet, erythema of palms and soles. So all of this is pointing towards the which criteria? Cream criteria. And cream, what do you remember about cream? Can anybody tell me about the cream criteria? Can anybody tell me about the cream criteria? So yes, there is. What is cream? What is cream? Can anybody tell me? What is cream? What is cream? Yes, there is conjunctivitis. There is conjunctivitis. There is a rash. And there is erythema. Very good. The conjunctivitis is non-purulent. Very good. Because this was also asked in the INI-set paper, right? There's adenopathy. And this is most likely cervical adenopathy, which is unilateral, and mucosal involvement. Okay, mucosal involvement in the form of strawberry tongue. Now, strawberry tongue can also be seen in scarlet fever. But how do you differentiate between the two? Scarlet fever, remember the fever is less than 5 days. Okay, less than 5 days. What about Kawasaki? The fever will be more than 5 days. Okay, more than 5 days. What about Henoch-Schfnlein purpura? Henoch-Schfnlein purpura can also be known as non-thrombocytopenic purpura. Purpura. Okay, non-thrombocytopenic purpura. So this is the kind of purpura that actually has it is a small vessel vasculitis. It is an immune mediated vasculitis. Immune mediated vasculitis. Okay. Remember, your Henoch-Schfnlein purpura happens in children, pediatric patients. Okay, pediatric patients. So remember, these children will call their papa. Okay, pa. So purpura, papa. ठीक है, Henoch-Schfnlein purpura, papa. What do you need to remember about papa? Can anybody tell me? What are the features that you see here in Henoch-Schfnlein purpura? Firstly, can anybody tell me? There is pain. How is the pain? Pain is abdominal. Okay, abdominal. There is presence of joint involvement, joint pain also, which is arthralgia. Arthralgia. Okay? There is palpable purpura. Very good. purpura, which is non-thrombocytopenic. It does not, remember palpable purpura, normal platelets. Okay, the platelets are normal. It is not because of the platelets. What about this? There are IgA deposits. Okay? And H is hematuria. You can also see hematuria. So if it progresses further, it can lead to RPG in type 2, right? Okay. So with this, I think we are done with 30 questions and we can end the session here. These are the most important questions. I'm sure many of them will come in the exam. There are more questions, but I think this is enough. Okay, this is an image of Henoch-Schfnlein purpura. Okay, there are 10 more questions, but I think we can end here, right? I think we can end here. Or do you want me to quickly go through the rest of the questions? Do you want me to quickly go through the rest of the sessions? Thank you. Thank you. Thank you so much, guys. Okay, just look at this question. Like, let's just quickly go through. Let's not solve. Let's just quickly go through them. Okay. Look at this. A 17-year-old male. So this is a very important question. Very, very important question. Collapses during basketball game. His medical history: exert, palpitations, acute shortness of breath. Systolic murmur was there with 𝗬𝗃 maneuver. Thickening of the interventricular septum with obstruction to the left ventricular outflow tract. Family history was there, where his paternal uncle died at age. So see, this is actually an autosomal dominant disorder. And which kind of cardiomyopathy this is? Yes, this is your hypertrophic obstructive cardiomyopathy, restrictive cardiomyopathy. Remember, it is seen in amyloidosis. The most common cause of restrictive cardiomyopathy affecting the diastolic function is amyloidosis. Very, very important. Please. This is actually where there are fatty streaks. Okay. It is associated with fat. And dilated cardiomyopathy, the most common cause is idiopathic, but after that, the most common cause is alcohol. Okay. So remember your hypertrophic cardiomyopathy, there is a sudden death in a young child. There's a defect in beta myosin heavy chain. And you can see this myocytes disarray, right? There is a disarray of myocytes. Disarray of myocytes, where the myocytes are going here, there. Okay, you can see this. This is known as the 𝗬𝗃 appearance. Plus this ventricle is the banana-shaped ventricle, right? What about dilated cardiomyopathy? Most common type. It dilates all the 4 chambers. Most common cause is alcoholism. Hemochromatosis also causes dilated myocarditis, cardiopathy. And genetic, the titin mutation. You must remember, it shows you the ninja nuclei. Okay, so this is my favorite. Titin gene defect, and it shows the ninja-shaped nuclei. Because anybody who has ever read manga or watched anime can relate with me why this is very close to our hearts. Okay, Takotsubo cardiomyopathy, this happens because of a stress, okay? Emotional stress that affects, that releases a large amount of catecholamines that affect the left ventricle. So there's hypertrophy of only the left ventricle, dilation and hypertrophy of only the left ventricle, okay? So remember, this is also known as the broken heart syndrome. And this is because of stress, okay? Not your stress is different, all right? Your stress is different. And if you can see the salmon pink appearance of what is deposited here, amyloid. This is dysfunction in the diastole, because something is sitting in the heart, right? Because of that diastole, the relaxing is affected, okay? So remember, restrictive cardiomyopathy, it is associated with amyloid. Quickly tell me the answer of this. Quickly tell me the answer of this. A 12-year-old male, streptococcal infection, now has joint pain. Histological appearance. So you can see this shows fibrinoid. necrosis. Okay, fibrinoid necrosis with presence of Henoch-Schfnlein cells. Okay, these cells are nothing but the Henoch-Schfnlein cells. Okay, and this is your Aschoff bodies which are seen in RHD. Okay, RHD. And what is the criteria in RHD? Can anybody tell me what is the criteria? What is the criteria in RHD? What is the criteria in RHD? Jones criteria. Very good. Okay, Jones criteria. Duke's criteria is in infective endocarditis. Okay, very good. So you see this mitral stenosis will present with the fish mouth. Okay, chronic RHD where you have mitral stenosis will present with the fish mouth appearance. Okay, or maculum patch. Right? So you go through all these endocarditis, all right, table. While this one, quickly, I think you can tell me these ferruginous, these dumbbell-shaped bodies, if they have iron around them, are known as ferruginous bodies, which are seen in asbestosis. Remember, the most common industrial infection or industrial, yes, asbestosis. But out of them, the most common is silicosis. Remember, it is associated with TB. While asbestosis, we just discussed now, the kind of malignancies it is associated with. Okay, cotton is byssnosis. Byssnosis. Okay, byssnosis. Yes, you can see eggshell calcification on X-ray in silicosis, right? This is the most common occupational disease. Carbon, you can see Kaplan syndrome, progressive massive fibrosis is seen. All right. So these are this eggshell calcification, it is seen in silicosis. Okay. Look at this question. This question is important because again, it was asked in INE set. Can you see this 40-year-old female? See, when they talk about a female itself, whenever they talk about a female or a non-smoker, and they are talking about all these lung, all these clinical features like shortness of breath, persistent cough with significant weight loss, they are talking about, most likely they're talking about adenocarcinoma. Okay? So smoking, when we talk about lung cancers, there are 4. Out of them, 2 of them are strongly associated with smoking, right? Like squamous cell carcinoma associated with smoking. Small cell lung carcinoma, it has the most specific, strongest association with smoking. But your adenocarcinoma is not associated with smoking. Okay? It is not associated with smoking. The second thing you can see here is glands. Okay, you can see glands, you can see mucin releasing, you can see glands releasing mucin. So this must be a tumor with glandular differentiation. Carcinoma with central bronchial lesion and keratin pearls is squamous cell carcinoma. Any squamous cell carcinoma will show you the presence of keratin pearls. Okay, and then your endocrine tumor with high mitotic rate and necrosis, this is actually small cell. Small cell is nothing but an endocrine tumor. Okay, small cell lung carcinoma. Okay, so go through this table. This table is very, very, very important. All right, this table is very, very important. 𝗲𝗵𝗺 effect. Yes, this is the 𝗲𝗵𝗺 effect, the famous 𝗲𝗵𝗺 effect. 𝗲𝗵𝗺 effect, where the tumor cells are falling off. Okay, they're falling off on the blood vessel, and you have a bluish hue of the blood vessel. What about these cells? What about these? These are your keratin pearls. Okay, keratin pearls. Remember, if they talk about lung cancer in non-smokers, mostly females, will be EGFR positive and will most likely be adenocarcinoma. What about this? Just quickly tell me. Quickly tell me about this. A 25-year-old patient with chronic diarrhea, weight loss, iron deficiency anemia is there, and elevated transaminases. Duodenal biopsy is given below. What do you see? You see villus atrophy. Okay, villi are supposed to be like this, but now you have atrophied villi. Okay, plus there is crypt hyperplasia. Okay, you can see so many crypts are there. So villus atrophy with crypt hyperplasia. Okay, where is this seen? This is seen in gluten sensitive enteropathy. When I talk about malabsorption due to a tropical infection, this must be related to E. coli, and this must be tropical sprue, where all the parts of the intestine are affected. So duodenum is affected, your duodenum is affected, so you have iron deficiency anemia because duodenum absorbs iron. Then your jejunum is affected and your ileum is affected. So vitamin B9 and B12 is also affected, and so you end up with iron deficiency anemia and megaloblastic anemia. Okay, segmental inflammation, this is seen in Crohn's, right? Skip lesion, yes, segmental is seen in Crohn's. And bacterial infection, this one line is so important, because bacterial infection like Whipple's disease, right? Trophiema whipplei causes foamy macrophages. When these macrophages try to eat up these bacilli, right? Where do they eat them? In lamina propria. So this is actually your Whipple's disease. All of them are very important for the exam. So go through them. This is one table that you have to go through. ठीक है. Yes. So you can see celiac disease it is associated with dermatitis also. Can anybody tell me which kind of dermatitis? So dermatitis is an extraintestinal manifestation, right, of your celiac disease. Can anybody tell me the dermatitis it is associated with? Anybody? Can you tell me the dermatitis it is associated with? Dermatitis, the extraintestinal manifestation. Celiac disease. Which dermatitis is it associated with? No. Something else. Somebody tell me. Dermatitis herpetiformis. Very good. Herpetiformis. Okay, this is the extraintestinal manifestation. You have IgA deposits. Okay, very important. All right. So remember, gluten, it is gluten sensitive, right? So where do you see gluten? Barley, wheat, rye, and oat. Okay, barley, wheat, rye, and oat. All right. So these are the things that you need to remember. Here in the lamina propria, you see the foamy macrophages. Okay, foamy macrophages in the lamina propria. And they are PAS positive. Remember this magenta stain. It is PAS positive. Okay? Remember this. Duodenum, I told you, no, iron will be affected. Jejunum, your B9 and B12. So it causes all these anemia, and lymphatic transport is affected in Whipple's. Very important. Look at this quickly. Just 4 more questions. We are done. This is a question where you have, a 35-year-old abdominal cramps. Look at the last line. There is segmental bowel thickening with cobblestone appearance. Where do you see cobblestone appearance? Yes, very good. So whenever there are big questions, right? Big, long questions, what do? You look at the last lines. Okay, last line gives you, in a big question, the last line gives you what the examiner wants from you, right? So this is most likely Crohn's disease. Ulcerative colitis is a kind of a pancolitis, right? So it is going on. There are no skip lesions, but it affects the mucosa and the submucosa, right? So if I talk about irritable bowel syndrome, inflammatory bowel disease, there are 2 that you need to remember: ulcerative colitis and Crohn's disease. Okay? So how do you differentiate between them? What starts from rectum? Ulcerative. Okay, starts from rectum and goes backward. Okay, so it is also known as a backwash ileitis. Smoking is protective. This is submucosal disease. It does not involve all the layers, and the spread is continuous. While Crohn's disease can affect any part, but most commonly it affects the terminal ileum. Okay, it has a NOD2 gene predisposition and it is transmural. Skip lesions are characteristics. Okay, so you can see this is actually the string of Cantor, where you see this stricture and fibrosis, then the normal bowel loop, right? Then again a stricture because of fibrosis. So this, yes, you can see skip lesions are there in Crohn's disease. Ileum involvement is there. And your string of Cantor, guys, string of Cantor is non-specific because it is also seen in genital TB. Okay, also seen in genital TB. Okay, it is also seen in genital TB. Also, you see can you see there is a giant cell? So most likely this is a granuloma. Remember, granuloma is hallmark of Crohn's disease. Okay. You have fibrosis as well as fistula formation. Fibrosis because of the healing, right? And rectum is spared. Remember, rectum is spared. And it can affect any part of the GIT. Okay. What about this? This lead pipe appearance. This lead pipe appearance. This is seen in, because of the loss of horstrations, this lead pipe appearance is seen in ulcerative colitis. Okay. And these are the common manifestation in both. What about this, guys? Just tell me fast. So you see a stain on one side of the face, and this is because of the trigeminal nerve involvement. V1 and V2, right? Trigeminal nerve involvement. Okay. And because there are leptomeningeal, yes. And you can see the port wine stain here. You can see the port wine stain. And there are leptomeningeal and tumors in that side itself that leads to seizures. Okay, it can also affect the ophthalmic branch, causing glaucoma. Okay, and this is seen in 𝗙𝗃-Weber syndrome. 𝗙𝗃-Weber syndrome. What about, yes, also tram tract calcifications are seen. Very good. Very good. What about your NF1? NF1 actually is a defect in, I'll just tell you, it is a defect in, it is present on chromosome 17, a defect of neurofibrin. No need to write the protein, but it is present on 17. It presents with Lisch nodules or 𝗵𝗵 spots. Okay. Okay. What about NF2? It is associated with MCI lesions, right? Multiple inherited schwannomas. Then you have meningiomas. Yes. And an ependymoma. Okay. Tuberous sclerosis, guys, this is again autosomal dominant, also known as Bournville disease. Okay. Tuberous sclerosis, what do you remember about this? This is a defect in TSC1 and TSC2 gene. And you also have hypopigmented macules, right? So these are your Lisch nodules. What are these? These are hematomas in the iris. You also have these spots. What are these? These are the 𝗵𝗵 spots. Okay, 𝗵𝗵 spots. 𝗙𝗃-Weber syndrome, trigeminoencephalic malformations, leptomeningeal angiofibromas on the same side. Okay, ends up with seizure, glaucoma, and your port wine stain. What about your tuberous sclerosis, you see this hypopigmented macule, which is your ash leaf macule. Very important. Also, you see chagrin patch, usually on the back. Okay? Look at this question now. We are just done. Okay, we are just done. Yeah. Very good, Gautam. Very good. Look at this. So there is hepatomegaly, diabetes, unusual dark tan, and minimal sun exposure. With minimal sun exposure. But so this is a triad, right? What's the triad? This patient might have liver cirrhosis with a bronze tan with diabetes. This is actually the triad of hemochromatosis. Alpha-1 antitrypsin deficiency will present with emphysema and liver cirrhosis. If you remember, what kind of emphysema? Pan-acinar. So they'll usually give you a female. Okay? Wilson's disease is a defect in ATP7B, and that causes increase in copper. Okay, so there's a copper overload that leads to liver cirrhosis. All right, that leads to liver cirrhosis. So this one table, go through them. Very important. These are the features of your KF ring. Okay, 𝗏𝗃 ring in the Descemet's membrane, your sunflower cataract. And the panda sign. Okay, all this are seen in Wilson's disease. What about this one? Second last question. Look at this. A 7-year-old child presents with morning headaches. MRI shows a midline cerebral mass. Okay, the following image is given. So if this is actually tumor cells, okay, tumor cells with some pinkish material inside it, right? This is known as which rosettes? Can anybody tell me? Which rosettes are these? Can anybody tell me? Homer, right? Pseudo rosettes. Okay, pseudo rosettes. Okay, Homer, right? Pseudo rosettes. Flexner's rosette is seen in retinoblastoma, not here. This is a 7-year-old child. So you can rule out neuroblastoma. See, neuroblastoma happens in a child which is less than 2 years old. Okay, abdominal mass which is less than 2-year-old. Neuroblastoma. Remember, neuroblastoma happens in a child less than 2-year-old. So you can rule that out right away. And this is a cerebral mass with pseudo-rosettes. So the answer is medulloblastoma. What about ependymoma? I just told you it is associated with NF2. All this, astrocytoma, ependymoma, glioma, all of them are glial tumors. Okay, what tumors are there? Yes, they are glial tumors. Which kind? So there are 3 glial tumors, right? You have astrocytoma, oligodendroglioma, and ependymoma. Your astrocytoma is further divided into grade 1, grade 2, grade 3, grade 4. Grade 1 is juvenile pilocytic astrocytoma, where you have a cystic mass on the cerebellum. So remember CEC. Okay, it happens in children, and it is cystic lesion on the cerebellum. The same thing, children on the cerebellum. This, remember, is the most malignant CNS tumor of children. So medulloblastoma, it is seen in children in the cerebellum. What about your pilocytic astrocytoma? That is also seen in cerebellum, but now there is a cystic lesion. Okay, there is a cystic lesion. What about on microscopy? You see Rosenthal fibers. The grade 4 astrocytoma, remember, it is also known as glioblastoma multiforme. And this is the most malignant tumor in adults. What do you see here? You see pseudo-palisading of cells. Okay, so you have these tumor cells that are stacked against each other. So this is pseudo-palisading. And in the middle, you see necrosis. So this pattern is known as serpentine pattern also. Okay, so necrosis and pseudo-pelluciding of tumor cells. Okay, and on gross image, you see a butterfly glioma. What about your oligodendroglioma? This is a grade 2 tumor. It is present on the frontal lobe. You see the famous fried egg appearance. Okay, fried egg appearance, it is seen in hairy cell leukemia. It is seen here also in oligodendroglioma. Then ependymoma. Remember, this is seen in either in children in the fourth ventricular, spinal cord, in adults. Like I told you, it is associated with NF2. And on microscopy, you can see perivascular pseudo-rosettes. Okay. Yes, fried egg appearance is also seen in hairy cell leukemia. All right. Yes, very good, Gautam. Very good, Megha. Look at this. This is the last question for today. A 40-year-old male presents with severe colicky flank pain to the groin. He has a history of recurrent episodes of similar pain. Urine analysis shows blood is given below. And abdominal X-ray shows most likely radiolucent, I think, shadow in the right renal pelvis. Which of the following is the most common type of renal stone here? So you can see different shapes, right? Different shapes. And this is most commonly uric acid. Yes, irregular shapes, different shape. So remember, calcium oxalate, you can divide it into calcium oxalate crystal, monohydrate or dihydrate. Monohydrate will show you a dumbbell appearance. Dumbbell. Okay, what about dihydrate crystals? Dihydrate will show you DE. Okay, dihydrate. Remember, dihydrate envelope appearance. Okay, envelope appearance. So your crystals ultimately make up the stones, right? Crystals together, if they keep on forming, then they make up your renal stones. So uric acid, it is associated with, Łyżwiak syndrome. Łyżwiak. Or your, can anybody tell me any other disorder where you have increase in uric acid? Łyżwiak is HGPRT. Can anybody tell me? Uric acid. HGPRT is Łyżwiak syndrome, or it can be because of gout, right? Gout also has an increase in uric acid. Your struvite crystals are also known as triphosphate crystals. Remember, these make the staghorn calculi. Okay? So they are seen in females mostly because of a protease infection. Yes, staghorn calculi. Very good, very good. And cystine, guys, cystine is hexagonal in shape. Okay. Struvite is what shape? Struvite. Can anybody tell me the shape of the crystal? Yes, alkaline urine. Very good. What is the shape of struvite? What is the shape of struvite? So let's just go through this. This is your monohydrate crystal, which is the calcium. Remember, coffin lid. Very good, very good. This is calcium monohydrate crystals. What about this envelope shaped is dihydrate crystals? Remember, this is the most common. Calcium oxalate crystals are the most common seen in acidic urine. Okay. What about this 6 sides? Okay, 6 is cystine. All right. It is seen in acidic pH. Again, radio opaque. They are very radio opaque and very hard. So shock waves will not be useful for them. What about different different shapes? These are seen in uric acid crystals. Remember, they are radiolucent. So when you write radiolucent, the U, remember, it is for uric acid. Okay. And risk factors include gout, Łyżwiak syndrome. What about your struvite? You have this very famous coffin lid appearance, and you have alkaline urine, and most common in females associated with protein infection. There are other crystals as well, like these 4. Okay. Let's end the session now. I hope this was useful to you and you were able to revise the most important questions that were there in pathology. like gone through all in as much short time as possible. Just go through this PDF once. And also there was another T&D that I had done. Go through that PDF as well. Thank you so much. Thank you so much for attending. See you next time. Okay. Thank you so much for attending. Thank you. Thank you so much. Thank you. So you can always contact me if you have any doubts. Please do contact me. Do let me know. Okay. Thank you, guys.